All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day today. Today we're going to be diving into 4 of the most important toxicologic emergencies in emergency critical care medicine. And that is beta blocker overdose, calcium channel blocker overdose, salicylate toxicity, and acetaminophen toxicity. These are poisonings that can rapidly progress to shock, severe acid-base derangements, liver failure, cardiovascular collapse, and multi-organ dysfunction if we don't recognize and intervene early. In this masterclass, we're going to break down the underlying physiology behind each overdose, the classic clinical presentations, the highest yield diagnostic clues, and the evidence-based management strategies that actually matter at the bedside. We'll cover topics like bradycardic shock, hyperinsulinemic euglycemic therapy, sodium bicarbonate and alkalinization, dialysis indications, N-acetylcysteine, airway considerations, vasopressor strategies, key pitfalls, and much more. The goal here is not just memorization. It's building a framework for recognizing and managing these critically ill toxicology patients in real time. No further ado, let's get into it. All right, welcome to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day. We're coming off a stretch of shifts. Actually had an interesting case, very classical, even though most patients don't fit the usual textbook. And it was elderly female. I guess unique features were that she was not on any immunosuppressive therapy or had immunocompromising conditions. That'll be relevant later. And she came in with that refractory pneumonia. Saw her PCP a couple weeks ago, got antibiotics, didn't get better, came into the hospital, got broad spectrum antibiotics, still didn't get better, and actually ended up needing the intensive care unit where she had to get intubated. She got ARDS, proning the whole gambit. But if I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. She had like 2 subtle skin lesions that looked really classical for actually blastomycosis. And lo and behold, both blood tests and biopsies of the lesion, she actually had disseminated blastomycosis. So got her on the appropriate therapies now, and hopefully we'll be doing a little bit better. But nonetheless, that refractory pneumonia, that's failing all these antibiotics. Good thorough exam, I'm sure our infectious disease colleagues would agree, can sometimes reveal something that you maybe weren't expecting, especially in someone like her who isn't immunocompromised and all that jazz. But anyway, today we're going to be talking about beta blocker overdoses. Didn't see any of those on our stretch of shifts, which is probably a good thing. But we're going to go into beta blocker overdoses today. What are beta blockers? We'll talk about classes and properties, formulations. We'll talk about the epidemiology of beta blocker toxicity, mechanism of toxicity, clinical presentation, diagnostic workup, initial ED and ICU management algorithm, including pharmacotherapies to treat it. We'll talk about kind of advanced therapies for it as well, some adjunctive therapies, some kind of advanced hemodynamic therapies, how to monitor, what the prognosis is, and then we'll do a little practice questions at the end. This study guide will be updated on our Patreon page as is usual, so we'd love for you to check that out if you have an interest in getting the study guide. And no further ado, beta blocker toxicity. So most people know this, but we're going to start by what are beta blockers. So beta blockers are commonly prescribed medications. Indications that they're used for are hypertension, ischemic heart disease, arrhythmias, heart failure, migraines at times, essential tremors, thyrotoxicosis. So lots of indications. Most primarily is probably for hypertension, ischemic heart disease, arrhythmias, and heart failure. Those are probably going to be the majority of indications that you see. But lots of patients are on beta blockers, right? Metoprolol, atenolol, carvedilol, all these are beta blockers. There are slightly different classes and properties to beta blockers. So there's the cardioselective beta blockers. These are beta blockers that primarily work on the heart, the beta-1 receptor, hence cardioselective. And these are things like metoprolol, atenolol, and bisoprolol. These are all cardiac selective. And then there's non-selective beta blockers, which work on the beta-1 and beta-2 receptors. So they're not just selective for the heart. And these are things like propranolol, nadolol, and timolol. And then there's some beta blockers that actually have mixed effects, alpha and beta receptors. This can cause some vasodilation from the alpha blockade. And these are things like labetalol and carvedilol. All right, so there's some mixed classes and actions of these beta blockers, and this can become significant in toxicity, although the selectivity is dose dependent. So in significant toxicities, you sometimes lose this dose dependent receptor selectivity, and you'll get beta 1, beta 2, alpha, all that kind of stuff. If we're talking about beta blockers, they do a couple different things. Obviously, they'll block these receptors and they can slow down the heart rate and they can optimize myocardial oxygen demand and all that good stuff. But they also have a couple other effects too, and these effects become relevant in toxicity. So one of these is intrinsic sympathomimetic activity. And this essentially means that they may produce less bradycardia in overdose. And these are things like acebutolol and pindolol. These are not common, at least not in the States. I don't know about other places, but just know that they exist. There's membrane stabilizing activity of beta blockers too. The sodium channel blockade, which will become relevant in toxicity as well. And beta blockers that have more of this effect are things like propranolol, again, acebutolol, and bitexolol. Propranolol is used. Again, we don't see acebutolol or bitexolol very often, but this can lead in toxicity to QRS widening and ventricular arrhythmias because of that sodium channel blockade. Again, we'll talk more about it. And then do note that they're lipophilic. Many of them are, at least. And lipophilic means they're fat-loving, which means it can cross the blood-brain barrier and cause CNS toxicity. Focus on propranolol. You can start to see propranolol's got a lot of these properties that can be dangerous in toxic doses. Metoprolol, which is a very common beta blocker, and carvedilol. So we'll be coming back to these classes and properties as we go through this discussion, because again, this is going to become relevant for some of the symptoms and things we have to do to manage them. As with any toxicity, formulation is incredibly important. You know, we've talked about a couple different toxicity pathodromes, and we have a whole playlist on kind of toxidromes. And for any of you that have seen those, formulation is incredibly important because immediate release is going to act different than extended or delayed release. And the timeline is quite important in these cases, right? If it's immediate release, you're going to have peak absorption of what you took at a certain time, where if it's extended release or delayed release, you might have a much more prolonged toxic period rather than kind of the more expected timeline in someone who took immediate release. So why does this matter? Why are we talking about beta blocker overdose? Well, beta blocker overdose can cause patients to get incredibly ill. This is one of those overdoses that, makes you really, really nervous when you're in the clinical arena, me included, because you can get this rapid cardiovascular collapse, you can get neurotoxicity, and you need to really intervene aggressively and quickly, right? Consider early decontamination, trial something like glucagon, high intensity insulin, vasopressors, bicarb, lipid emulsions, even ECMO, right? All things we'll talk about as we go through this discussion. Okay, epidemiology, just quick. How often does this happen? Well, beta blockers are obviously common among cardiovascular drug overdoses. Propranolol is frequently implicated in severe CNS toxic cases, right? Because as we said, propranolol is lipophilic, it's fat-loving, so it crosses the blood-brain barrier. Mortality increases in these patients with delayed recognition, extended release formulations, co-ingestants. This is one of those other things that for any toxidrome, you need to always think about and ask about co-ingestions because they will affect, 1, the symptoms you're having, 2, how to manage them, and 3, sometimes the absorption of the drug too. And then, so mortality increases with delayed recognition, extended release formulations, co-ingestants, and then any lipophilic or membrane stabilizing agents, right? Lipophilic being crosses the CNS, crosses the blood-brain barrier into the CNS, and MSA agents, things like sodium blockade, which can cause QRS widening and significant arrhythmias. So mechanism of toxicity. Mechanism is important because this will then drive symptoms. So if you understand mechanism, you then can extrapolate and understand symptoms. And as we talked about, beta blockers have beta 1 blockade action, beta 2 blockade action. Some of them have sodium channel blockade action. Some are lipophilic. And then we're going to talk a little bit about a specific beta blocker, sotalol. But beta 1 blockade, beta 1 receptors are in the heart. Right? If anyone saw any of our vasopressor episodes, we talked a lot about the different receptors in the heart and peripheral vasculature. But beta 1 receptors are in the heart, so when you block them, you're going to cause negative inotropy. Inotropy being how good the heart is pumping out blood, how good it's squeezing. So that's going to go down. Negative chronotropy, which is heart rate. So we'll write inotropy is squeeze, chronotropy is heart rate. So both of those are going to go down. And as one can imagine, then you're going to get bradycardic, or low heart rate. You're going to get hypotensive. You can get AV blocks, and you can go into cardiogenic shock. Really serious stuff. Beta blockers, though, if they're non-selective, or even if they're cardioselective and you take high doses, can also have beta 2 blocking effects. All right, and this can cause peripheral vasoconstriction, bronchospasms, and hypoglycemia. We have an episode out on calcium channel blockers, and one of the big challenges is differentiating beta blockade from calcium channel blockade. And the glucose can be quite helpful because in calcium channel blockade, if anyone watched that episode or listened to it, you actually get hyperglycemia. And in the clinical arena, does this always happen? No, but textbook answers and test questions, calcium channel blockers, you'll have hyperglycemia. Beta blockers, you'll have hypoglycemia because you get decrease in glycogenolysis and gluconeogenesis. This is especially common in children. We mentioned that beta blockers can have some sodium channel blockade, and that's going to cause QRS widening. It can cause ventricular arrhythmias, more common with propranolol. Beta blockers that are lipophilic get into the CNS, into the brain, and can cause CNS depression, seizures. Again, propranolol is a big guilty drug for this one, but metoprolol and carvedilol, which are two common ones, can also do this. All right, so you can get some CNS depression, seizures. And then sotalol is non-selective, but it also has this class 3 effect. We've talked about sotalol. We have a whole series on antiarrhythmics, so definitely check that out if you're interested. But sotalol can cause torsades through its QT prolonging pathway. So if we think about the mechanism of toxicity, the 4 main things to think about are beta 1 blockade, beta 2 blockade, sodium channel blockade, and lipophilicity. All right, and beta 1 blockade, you're going to get bradycardia, hypotension, AV blocks, cardiogenic shock. Beta 2 blockade, you're going to get bronchospasm, hypoglycemia. Sodium channel blockade, you're going to get QRS widening, you get ventricular arrhythmias. And if it's a lipophilic beta blocker, it gets into the brain and causes CNS depression, seizures, all that good stuff. So this is then going to translate into clinical presentation. And we break it down by system here: cardiac, neurologic, respiratory, metabolic, and then timeline. So as we mentioned, cardiac, you're going to get beta 1 blockade. So you're going to get sinus bradycardia. You're going to get junctional rhythms, AV blocking rhythms. You get hypotension and shock. And then if it's a sodium channel blocking agent, you can get ventricular dysrhythmias. And if it's sotalol, you can get torsades. Okay? Neurologic effects. If it's lipophilic, remember propranolol is a big guilty lipophilic one, as well as metoprolol and carvedilol, which are 2 common ones. All of these are lipophilic. All of these can get in the brain. So you can get lethargy, coma, seizures, specifically. Respiratory, we also mentioned that beta blockers have beta 2 effects, especially at higher doses, even if they're cardioselective, and then cause bronchospasm. It can even cause apnea. Beta 2 doesn't cause apnea. CNS depression can cause apnea, but you can get bad bronchospasm with the beta 2 blocking effect. Metabolic, remember, hypoglycemia. Calcium channel blockers, hyperglycemia, metabolic hypoglycemia, and you can get a lactic acidosis. The timeline here, remember, is it extended release or is it delayed onset? If it's extended release, the timeline is usually 1 to 2 hours. If it's, did we say that right? If it is immediate release, the timeline is often 1 to 2 hours. If it's extended release, you might have delayed onset, 6 hours, 12 hours plus, sometimes even 24 hours, depending on if there's co-ingestants and things. So immediate release, 1 to 2 hours. Delayed or extended release is just going to be much longer, greater than 6 hours, maybe approaching 24 hours. All right, diagnostic workup. Well, obviously you want these patients to be on continuous cardiac monitoring or telemetry. You want frequent vital signs depending on how bad the ingestion is. You want to get a basic metabolic panel. You need glucoses, right, because you can get hypoglycemia. All this is adding up. As long as we know the mechanism of toxicity, we can extrapolate symptoms and work up. You want to get LFTs, troponin, mag, phos, ABG, VBG, lactate, all that good stuff. You certainly want an EKG, looking for QRS widening, QT prolongation, all that. And then these patients go into cardiogenic shock. So you want to get a chest x-ray. You want to maybe POCUS some, think about pulmonary edema, look to see how their heart's doing, all that good stuff. All right, initial ED and ICU management. Well, with any initial ED or ICU management, step one is always going to be stabilize. Do they need to be intubated for severe altered mental status, seizures? Are they protecting their airway? Get some large bore IVs in them. Consider an arterial line. If it's a massive ingestion, low threshold to put an arterial line in, even a central line, right? Especially if the patient's in shock, because these patients most likely are going to keep getting worse if they had presented close after their overdose, rather than better initially. And then treat hypoglycemia. Check a glucose right away. So airway, breathing, circulation, glucose. Recheck frequently if it's low. Decontamination. If this is a really, really recent overdose, they come in within an hour of taking their beta blocker, maybe even 4 hours if it's extended release, you can give activated charcoal, right? This can cause patients to have a lot of GI issues, and as such, airway protection is important to note, because the last thing you want is for to give them activated charcoal and then they aspirate and it causes all sorts of issues. People talk about whole bowel irrigation. This is not something that we have classically done. So with all of this, we should have said this even earlier, call Poison Center. And you can Google the number in your area. They are an incredible resource. These patients are very sick. Call your Poison Center. They will help you out. All right, first line pharmacologic measures. Well, if it's symptomatic bradycardia, you can give a dose of atropine, but this is just going to be transient, right? It might not even be effective at all, and this should not delay definitive therapy. So if you want to give a dose of atropine, go for it, but you shouldn't be sitting there banking that the atropine is going to actually be effective or sustained, because it won't be. You can trial glucagon. Realistically, you probably should trial glucagon. This is a bolus usually. If there's no response, you can consider repeating it. You can even do infusions, but this causes a lot of emesis, a lot of vomiting. So really, really, really consider pre-medicating with an antiemetic, and just know they're probably going to vomit. So if you got a patient whose mental status isn't great, they're not intubated, just give them a bunch of glucagon, they might puke and aspirate. So just be really careful with that. Calcium is something people talk about. This is a mainstay of treatment for calcium channel blocker overdose, but the evidence in beta blocker is not super robust. You can try giving it to see if it helps folks. It is kind of like nature's vasopressor inotropes. You might get a little inotropy from the calcium, but much more center stage for calcium channel blocker overdoses. And then, vasopressors and inotropes. Are they hypotensive and shock? Do they have low contractility, low inotropy? Are they in cardiogenic shock? Think about epinephrine. Epinephrine has beta 1, beta 2, and alpha effects. So it'll start to overcome some of that beta blockade. Norepinephrine has alpha more than beta effects. So it has less effect on the heart, less kind of increased inotropy and all that. Dopamine is not something we recommend using, although people talk about it. We don't commonly use this, but isoproterenol can increase the heart rate, but it can cause some arrhythmias and hypotension. So, again, we don't classically use it. Really, epinephrine is a great drug in this situation, just because it has both that beta effect as well as that alpha effect. Again, if I'm speaking French and you don't speak French, if this sounds like French to you, check out our vasopressor episodes, because those will provide a lot of context on the different receptors of the different vasopressors. And you can find that on our page, or linked probably in the description of the episode and all that. We got it all over, so just hop on our page and check it out. Okay, advanced therapies. This is where things get a little complex. Just like calcium channel blockers, if you watch that episode or listen to it, high-dose insulin euglycemic therapy is really a central management option for these patients who are getting sicker. And what is literally happening is you're giving high-dose insulin, and the heart then can utilize carbohydrates. It's kind of like turbocharged, and it will cause cause an increase in contractility for those patients that have failed pressors and glucagon and all that kind of stuff. But notice this is high-dose insulin. So this is not medical advice. Please, don't act on this as if it is medical advice. We got disclaimers all over the place. So don't act on these doses or any of that. But just for context, usually this involves a bolus of around 1 unit per kilogram of insulin. That's a ton of insulin, right? Someone's 100 kilos. That is 100 units of insulin bolused. So these patients are going to get hypoglycemic. And we already might be battling hypoglycemia. So you got to give these patients tons of dextrose. Do it ahead of time. Don't be reactionary. People can die from hypoglycemia. So this is really serious. But this is a therapy that you probably will need to do. So you have to be very, very thoughtful in glucose management when you're starting this high dose insulin, because you're going to start then an infusion. This infusion is can be as high as 10 units per kilogram per hour. But usually you start at 0.5 to 1 units per kilogram per hour. So this is a very dangerous therapy, but one that can save a patient's life too. And you can do it safely. You just have to be very strategic in your glucose checks, making sure you're giving them extra dextrose as needed and really watching for hypoglycemia. The other thing here is potassium. Insulin shifts potassium intracellularly. So you have to monitor potassium, and if that potassium drops less than 3.5, we would even keep it closer to 4 to 5. If it drops less than 3.5, you really maybe should, depending on the clinical scenario, consider stopping the insulin for a little bit, because someone can obviously die of hypokalemia as well. So hypoglycemia, hypokalemia are two huge things that you need to monitor for and be very aggressive about repleting up front. Additional adjuncts. So if someone has taken one of those sodium channel blocking beta blockers, as we talked about, propranolol is one of them, and you get sodium channel blockade that causes QRS widening, you should give sodium bicarbonate, right? Sodium channel blockade gives sodium bicarbonate, increase the sodium load to try to overcome that sodium channel blockade. So if there's QRS widening, you really should consider giving sodium bicarbonate, 1 to 2 milliequivalents per kilogram bolus. You can titrate it to a pH of 7.5, 7.55, or a QRS that has normalized. And this can be, again, life-saving. You should be very thoughtful about this. If you see QRS widening, that's going to be a risk factor for going to ventricular arrhythmias, so you should be aggressive with your sodium bicarbonate up front. Patients who have Cs, right, maybe they took a lipophilic beta blocker like propranolol or metoprolol or curvatolol. Benzodiazepines as therapy for seizures is certainly indicated. Some of these patients need to be intubated, propofol, all that kind of stuff. The big thing to note here is that normal anti-epileptic drugs are not very effective in these patients. And if someone has sodium channel blockade, you want to avoid them, especially phenytoin. So treat the seizures with GABAergic medications like benzodiazepines or barbiturates or propranolol, or propofol. Do not give them propranolol. And then avoid kind of those anti-epileptic drugs, phenytoin specifically. If a patient's having bronchospasm, remember we said beta-2 receptors that can cause bronchospasm. So inhaled beta agonists, all that good stuff can be helpful for bronchospastic patients. Not that we've seen a ton of these, but we have seen them and they're always very, very sick. And bronchospasm isn't something that seems to anecdotally come up very often in these patients, but it certainly can happen. So be observant for it. Some of the other crazy tox stuff, lipid emulsion therapy for refractory shock from a lipophilic agent. So lipid emulsion therapy is literally you're giving intralipid into the bloodstream, and it's kind of these lipid bubbles sort of. And if you have a beta blocker like propranolol that's lipophilic, the lipid emulsion will kind of surround that propranolol and not let it have any effects on receptors. So propranolol, carvedilol, metoprolol, all those are lipophilic agents. Consider lipid emulsion to treat them. And then if someone's in torsades from sotalol, management's kind of classical, right? Give magnesium. You can consider overdrive pacing, all that good stuff. So these are adjuncts for kind of specific scenarios. And the thoughtful thing here is it a sodium channel blocking beta blocker like propranolol? If so, is there QRS widening? If so, give sodium back, sodium bicarbonate. Are they seizing? Treat them with GABAergic medications. Avoid anti-epileptic drugs. Are they bronchospastic? Treat them for bronchospasm, inhaled beta agonists. Is it a lipophilic agent like propranolol or curvatolol or metoprolol? Consider lipid emulsion. And then if they're in torsades because they took a bunch of sotalol, magnesium, which is classic. So patients, if they still continue failing these, right? You've tried everything. You've given them pressors and inotropes, and they're they've gotten their high-dose insulin. You know, maybe you have even trialed glucagon. Maybe they even up front got activated charcoal. You've given them sodium bicarbonate because it was a sodium channel blocking agent. You've given them lipid emulsion, and they still are failing. And there will be patients, if you practice in a place that's pretty busy with a lot going on and you do it long enough, there will be patients with beta blocker toxicity who fail all of these management therapies because it is such a deadly toxidrome if you take a lot of it. And if that's the case, you have to start thinking about rescue. How can we potentially rescue these patients? You've tried all the tips and tricks. You've been aggressive up front. You should be aggressive up front in big overdoses. Don't be reactionary. Be proactive. Get them on these aggressive therapies early, because if you're reactionary, there's going to be a lot of end organ injury that you're not preventing. Okay, so some of the rescue therapies. Obviously, you can try transvenous pacing for refractory bradycardia, but this sometimes doesn't work because sometimes their heart won't respond to it. So it can be unreliable, but you can try it. The big thing here is VA ECMO, veno-arterial extracorporeal membrane oxygenation. We've done some episodes on VA ECMO as well. Check them out. You can just search Whiteboard Medicine ECMO. That'll probably get it to you. And this is really what can be life-saving for these patients, right? Put them on VA ECMO, let their toxidrome pass, and they will get better. So don't delay this. If you're having trouble managing this patient, they're in fluid cardiogenic shock, you've trying all the things and they're not working. If you're not an ECMO center, get them to an ECMO center. If you are an ECMO center, let your team know. Let the ECMO team know that this might be a patient that needs to be cannulated. Every once in a while, what they took was a dialysable agent. These are ones like atenolol, nadolol, sotalol. So it's not a lot of them, and it's not the most common ones. But if it is a dialysable agent, you can obviously do hemodialysis to try to dialyze it off. This is not effective for propranolol. It's not super effective for many of the beta blockers. It might be somewhat effective for some of them, more effective for others, but it's not really effective for propranolol and some of the other ones. So you can certainly try this, but it might help you, it might not. So monitoring and course. For moderate severe ingestions and all extended release ingestions, just because you don't know how they're going to behave, they should really be admitted to the intensive care unit. These patients, again, aggressive early, right? Trend their lactates, trend their end organ perfusion markers like creatinine and LFTs and troponin and lactic acid. Put an A-line in them, have a central line if you need it. If you're doing high-dose insulin therapy, be checking those glucoses frequently, every 15-30 minutes, at least every hour. Watch that potassium, serial EKGs, telemetry monitoring, all that good stuff. And really be aggressive up front with these patients. Get ahead of it rather than reacting to decompensations. Prognosis, if you recognize early and you intervene aggressively, there can be some favorable prognosis. Obviously, this is to a degree. If you take too much and you're not in an ECMO center, you might not be able to keep up. But early recognition and early aggressive intervention is key. There are some poor prognostic indicators, as with anything: refractory hypotension, rising lactate, rising acidosis, recurrent dysrhythmias, need for ECMO. All these things suggest a poor prognosis, which probably isn't surprising to anyone. All right, we're getting towards the end here. Here's a quick reference, and we'll do a couple practice questions. Quick reference, especially for test questions and maybe even in the clinical arena. If you're unknown if it's beta blocker, calcium channel blocker overdose, look to the glucose. Beta blockers have hypoglycemia. Calcium channel blockers have hypercalcemia. Sorry, glycemia. Hypoglycemia for beta blockers, hyperglycemia for calcium channel blockers. First line therapy, ABCs, right? Classic emergency medicine teaching. If it's early, you can consider activated charcoal. You can consider glucagon, use your pressors. And if they're even showing borderline signs of malperfusion, start high intensity euglycemic, high insulin euglycemic therapy early on, and really titrate it. Watch those glucoses, watch those potassiums. If it's a sodium channel blocking agent, or if you don't even know if it is and the QRS is wide, give them sodium bicarbonate. If they go into torsades, give them magnesium. Consider overdrive pacing. If it's a lipophilic agent or even refractory shock, give them a lipid emulsion. And if you're having trouble keeping up despite this, ECMO. Okay? And always, we cannot say it enough, call your poison center. They will be a hugely helpful resource to you. All right, into a couple practice questions. For those of you who have seen episodes before, you know that we'll read the question, read the answers, and pause quick, and then go read the question, read the possible answers, and then pause quick and then go into the actual answer. So if you need more time to think about it, just pause the episode because we'll go into the answer pretty quick. So first question is a beginner question. 27-year-old woman presents 1 hour after ingesting an unknown number of metoprolol tablets following an argument. She's somnolent with a blood pressure of 80/45, heart rate's 38, glucose is 52, SpO2 is 98% on room air. Her electrocardiogram shows sinus bradycardia with a narrow QRS. After securing IV access and giving dextrose, the best next step is to A, start a glucagon bolus, B, administer IV calcium only, C, immediate transvenous pacing as the only therapy, or D, give naloxone and observe. All right, answer is A. So glucagon is a first-line pharmacotherapy for beta blocker overdose. You often are able to improve heart rate and blood pressure a bit. Calcium alone is not effective. Pacing alone is not effective, and naloxone doesn't really address the beta blocker overdose. So next step you would immediately do would be consider glucagon therapy in this patient. Next question, intermediate difficulty. 35-year-old man has a propranolol overdose. Empty 80 milligram extended release bottle found. He's confused. He seizes. His blood pressure is 75/40, heart rate is 30, electrocardiogram has a QRS of 160. After airway control and benzodiazepines, which single intervention is most appropriate now? A, give magnesium for torsades. Friendly reminder, they weren't in torsades. B, give sodium bicarbonate bolus and begin epinephrine. C, begin a diltiazem infusion. Hopefully no one chooses that one. D, start hemodialysis. All right, answer is B. Give sodium bicarbonate bolus and then begin epinephrine. So remember, propranolol has sodium channel blocking effects, which means that it'll cause QRS widening, and you treat that with sodium bicarbonate. Give it till the pH is 7.5, 7.55, or narrow QRS. This patient also has hypotension and bradycardia, so epinephrine, right? Epinephrine has both beta effects and alpha effects. Great drug for this toxidrome. So start epinephrine. It gives you some inotropy, some chronotropy, some vasoconstriction. Other options, magnesiums to treat torsades. This patient's not in torsades. Diltiazem would kill this patient. That'd be horrible. Propranolol is not dialyzable. Okay, and remember the patient sees because propranolol is also lipophilic, so crosses the blood-brain barrier and gets into the brain. So other things you can consider here would be intralipid, right? Would be the other thing to consider. But the next step would be sodium bicarbonate and epinephrine. All right, advanced, last question. 62-year-old with ESRD ingests a large amount of atenolol. 12 hours later, he remains hypotensive and bradycardic despite fluids, glucagon, epinephrine, high-dose insulin, calcium, lactate 7, pH is 7.24. What's the best next step? A, discontinue insulin due to acidosis. B, start hemodialysis while continuing high-dose insulin and pressors. C, administer lipid emulsion. D, add a third vasopressor and wait. This one's a little bit tougher. Answer is B. Start hemodialysis while continuing high-intensity insulin therapy and pressors. So atenolol is hydrophilic, it's low protein bound, and as such it is dialyzable. So hemodialysis will remove the drug, improve the hemodynamics. You obviously want to continue the insulin and pressors during dialysis till they're doing better. Lipid emulsion is more helpful for lipophilic agents like propranolol and carvedilol, rather than this agent being atenolol. And then stopping insulin and passively adding pressors without source control or any of that kind of stuff doesn't seem like the right thing. So dialyze patients who took a beta blocker that is dialyzable. All right, that's all we have for you today. We appreciate you checking it out. Let us know what thoughts, comments, questions you have. Check out our Patreon page, our YouTube or podcast, depending on what you're listening or watching this on. And then we have a newsletter too that we may crank up and be more active on, although our big focus right now is our YouTube podcast and Patreon page. So we'd love to see you on any of those platforms. And either way, stay well, keep learning. We'll see you next time. Hey everyone, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. We hope everybody is doing well today. I'm actually in between a stretch of ICU shifts, and I don't know if they've been putting TXA in the water or something, but there's been lots of really significant pulmonary emboli coming in. We had a clot in transit the other day, which is always a challenging a clinical conundrum, given risk with mechanical thrombectomy of trying to push that clot forward and embolizing it. Certainly, surgical embolectomy is a high morbidity procedure, although sometimes it's definitely indicated, and then you're always pondering, If I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. Do you give the patient thrombolysis, half-dose thrombolysis, what have you? So anyone who's taking care of patients clinically, we appreciate you. Anyone who's also had some PEs lately, certainly let us know. Luckily, though, we have not had any calcium channel blocker overdose just yet, but we'll keep our eyes peeled when we go to shift later today. Today, we're going to be talking about calcium channel blocker overdose. We'll be talking about what calcium channel blockers are, just briefly to introduce things. We'll talk about how often it happens, mechanism of toxicity, clinical presentation, diagnostic workup, initial management, advanced therapies, adjunctive therapies, rescue therapies, monitoring prognosis, and then we will get into some practice questions at the end. So we hope this is kind of a high-yield clinical education episode on all things calcium channel blocker overdose. These can be incredibly gnarly. As a friendly reminder, none of this is intended to be acted upon as medical advice. Please listen to the entire episode, and you can see the full disclaimer in the description or at the end of the episode. No further ado, calcium channel blocker overdose. What are calcium channel blockers? Well, I think many of us probably know this, but just to speak it out loud, calcium channel blockers are medications that patients take often to treat hypertension would be one of the main indications. Sometimes angina, right? That chest pain from kind of relative myocardial ischemia. Some patients are on calcium channel blockers for arrhythmias like atrial fibrillation with rapid ventricular response. Some patients take diltiazem. Migraine prophylaxis is another indication, although this one is not super common. The most common that you'll probably see would be for arrhythmias or hypertension, followed by angina, followed by migraine prophylaxis. But lots of patients are on these medications. There are two main classes of calcium channel blockers. Depending on where you're at in your training or post-training, this might be closer in your brain or further away, but they're dihydropyridines and non-dihydropyridines. Since this is not a video on calcium channel blockers, rather calcium channel blocker toxicity, we're not going to dive into the nitty-gritty details on these two separate classes, but we do just want to speak it out loud because, again, it is relevant for the toxicity. So dihydropyridines are potent vasodilators, okay? These have less cardiac suppression, less cardiac activity. So these are often used for hypertension, things like amlodipine, things like nifedipine, again, very common medications. Whereas non-dihydropyridines have greater cardiac effects. They work more on the heart. And because of that, they're more often used for things like arrhythmias. Okay, this is things like diltiazem. All right. Oh, we actually wrote them here. Perfect. Yeah, diltiazem and verapamil. These are common as well. People out there might be taking them that are watching this episode right now. But the dihydropyridines are more common than the non-dihydropyridines. The non-dihydropyridines, since they have more cardiac effect, have more negative inotropy, chronotropy, and dromotropy. So this is really a cardiac suppressants. And that makes sense based on what they're used for, right? They're used for things like arrhythmias. So we want to slow the heart down. We want it to squeeze maybe a little bit less. We want it to have less robust contractility, all to kind of suppress that arrhythmia. And as such, they have these greater cardiac effects. So when it comes to toxicity, as one may imagine, depending on which class of calcium channel blocker there's toxicity from, the dihydropyridines like amlodipine or nifedipine, or the non-dihydropyridines like verapamil and diltiazem, you'll have slightly different symptom profiles, although the management is relatively similar. So they are available in both immediate release and sustained release formulations. Anytime we're talking about toxicity from something, it's always important to tease out if it's immediate release or sustained release, because as the names imply, and as one would imagine, these have different kind of timelines in which you will absorb the medication, and the different timelines that you will absorb the medications in can then drive different therapies, and also the type of monitoring you're doing, and also where you might want to disposition that patient if you're in the emergency department, or how often you want to monitor that patient if you're in the inpatient setting. So why does this matter? Well, calcium channel blocker overdoses are highly lethal. Even as an emergency physician and intensivist, these are, these patients who have significant calcium channel blocker overdoses are terrifying. Very, very lethal. Patients get very sick, and they require aggressive therapy in the intensive care unit. All right. Things like high dose insulin that we'll talk about, and sometimes even ECMO, extracorporeal support. So let's dive into it. How often does this happen? What is the epidemiology? Well, calcium channel blockers account for a significant proportion of cardiovascular drug overdoses. All right. They're among the most lethal prescriptions when patients overdose on them. Like we talked about, very lethal, very scary when patients do overdose on these medications. Mortality can be close to 30 to 40% in severe cases despite aggressive therapy, high dose insulin, even ECMO, extracorporeal membrane oxygenation. The mortality is still very high. So these patients are sick. All right. Sustained release formulations are especially dangerous because they have that delayed onset and prolonged toxicity. One may imagine this, right? It's a sustained release formulation, so you're going to have slower release of that drug over time, and as such, you'll get a delayed onset of the manifestations of calcium channel blocker overdoses, and this can prolong the toxic profile. So how do these medications cause toxicity? I think all of us can start to kind of think in general terms about how that can cause toxicity, but what's the actual mechanisms that are at play here? Well, calcium channel blockers, if we think of the name, calcium channel blockers block L-type calcium channels. And they're in the myocardium, or the cells of the heart, the vascular smooth muscle, and actually pancreatic beta cells as well. And this is going to play a role when we think about the difference between beta blocker toxicity and calcium channel blocker toxicity. So remember this little factoid, pancreatic beta cells. But the other two are as expected, heart cells, so the myocardium, and vascular smooth muscle cells. The vascular smooth muscle coats the lining of blood vessels, right? There's all this vascular smooth muscle surrounding blood vessels. And when that vascular smooth muscle either contracts or relaxes, you get vasoconstriction or vasodilation. So if it's blocking calcium channels in vascular smooth muscle, that's going to cause the vasodilation. And if it's blocking calcium channels in myocardial cells, that's going to cause the cardiac suppression. And now we're starting to understand, we're starting to see how the toxicity symptoms we're going to talk about might result from this medication. So if we try to spell it out even further, the effects are cardiac depression, so decreasing contractility of the heart, slowed heart rate or bradycardia, and AV blocks. And as we mentioned, this is especially true of non-dihydropyridines because this has more cardiac effects than non-dihydropyridines like verapamil and diltiazem. So cardiac depression, you also get vasodilation. We just mentioned that smooth muscle relaxes and causes blood vessels to vasodilate, and this can lead to hypotension, low blood pressure, even kind of a distributive shock profile where you get that vasoplegia. Now, I wouldn't think of it like a classic SIRS distributive shock, but you do get that vasoplegia. And then the third thing is metabolic toxicity. We talked about how there's these L-type calcium channels in pancreatic beta cells. And when you inhibit those in pancreatic beta cells, you get inhibition of calcium-dependent insulin release. This then leads to hypoinsulinemia, which then leads to hyperglycemia. So you get increased glucose levels in calcium channel blocker overdoses, which is one of the, at least textbook differences between beta blocker versus calcium channel blocker. And we'll come out with a dedicated episode on the differences between the two, and we'll compare them and all that stuff. But the three main effects then are cardiac depression, vasodilation, and metabolic toxicity, which you can really think of as hyperglycemia. In the severe cases, the cases that keep me up at night, you can get cardiogenic shock, refractory hypotension, metabolic acidosis, multi-organ failure, and this can eventually spiral to death, despite aggressive care. So what does a clinical presentation look like? If we think about what the calcium channel blocker toxicity is doing from a mechanistic standpoint, we can then start to kind of extrapolate that to the clinical presentation. So early on, if it's immediate release, early on is just within a couple hours, 0 to 2 hours. If it's sustained release, you might see that up to 6 or 8 hours. You get general symptoms: dizziness, nausea, vomiting, some mild hypotension. And this progresses into those cardiac depressant effects as well as vasodilatory effects. And you start to get bradycardia, AV blocks, refractory shock. This can lead to altered mental status. You can get seizures, pulmonary edema from the cardiogenic portion of this. And the distinguishing features that represent in textbook questions calcium channel blocker overdose, and these do occur in the clinical arena too, it'd be a combination of profound bradycardia, hypotension, and hyperglycemia. And those are, if you think about kind of 3 textbook symptoms of calcium channel blocker overdose, those would be it. It'd be bradycardia, it'd be hypotension, and it would be hyperglycemia. So remember that for test questions, and again, also the clinical arena. All right, the diagnostic workup here mostly looks at end organ dysfunction. There's no magic, test that directly tests for calcium channel blockers. You have to go based on history alone and then the clinical pathognomon. So diagnostically, you obviously want vitals and a full cardiac workup and put them on telemetry monitoring. And then labs, you want to do a basic metabolic panel, look at the glucose, look at the renal function, get a blood gas, lactic acid, think about acid base, liver function tests, mag level, troponins, glucose, electrocardiogram to look for bradycardia, AV blocks. And then with any toxidrome, and we cannot stress this enough, so the most easily missed toxidrome is the second one. You might have a patient who, their family's like, we saw them take, 100 amlodipine tablets, and you're like, okay, I know this, I got this. It's calcium channel blocker overdose. I listened to that episode on Whiteboard Medicine. I got what's going on here, but you might then miss the co-ingestant, the second intoxicant. So test for co-ingestions. We can send Tylenol levels. We can send salicylate levels. We can send alcohol levels. We can test digoxin levels. And even the things we can't test, really push that history to see if there's other medications that the patient may have ingested. Because this can dramatically affect things, ranging from slowing your absorption of that drug and changing the timeline you're monitoring that patient, all the way to creating very complex mixed toxidromes. All right, now we've diagnosed it. We've thought about the mechanism, we thought about why it's happening. What can we actually do for these patients? The initial management, as with kind of all sick patients that come to the hospital, starts with stabilization. And it starts with the classic things. Make sure they're protecting their airway, because sometimes they can get so altered that they have trouble with airway protection. Make sure that they have great peripheral IV access. I personally have a very low threshold to put an arterial line in these patients. And then treat any glucose abnormalities. This was a typo. We wrote hypoglycemia, but hyperglycemia is more common in these patients. Decontamination after stabilization is something to consider. You can use activated charcoal if it's within a couple hours of ingestion and you have their airway protected. But if it's after that first couple hours, activated charcoal probably is not something that's going to be effective. All this is going to be guided by your poison center and a possible tox consultation, and obviously your clinical gestalt as well. But we always say, use your poison center, call them. If anyone's like, what's the number? Google it. Literally, poison center, insert your area, and the number will pop up. They're an incredible resource. But within the first couple hours, you can consider activated charcoal. Whole bowel irrigation is something that's discussed specifically for sustained release ingestions. We personally have never done that. Not to say we've had an opportunity to and actively chosen not to. We just haven't been in that situation. But again, it's not something that we would do without guidance from our poison center. After stabilization, after decontamination, your first line therapies are going to be, drumroll, IV calcium. Let's see if we can overcome the receptor blockade. All right, calcium chloride or calcium gluconate, repeat as needed. Sometimes they need a continuous infusion, but calcium to try to overcome the calcium channel blocking, which makes sense. Bridge these patients with vasopressors, norepinephrine or epinephrine for hypotension. Dopamine used to be something people used. We are not a big believer in dopamine for these patients, so use epinephrine if they're bradycardic, norepinephrine if they're hypotensive. You can trial atropine for bradycardia, although it's probably not going to provide any sustained benefit. But if you're in a pinch and you're trying to get a bunch of stuff together, you certainly can trial some atropine for bradycardia. So the first line therapies are going to be calcium to see if you can overcome that calcium channel blockade, vasopressors, either epinephrine, which can be helpful if they're a little bradycardic, or norepinephrine if it's really a hypotension issue. And you can trial atropine just to bridge them while you're getting everything together, but just know that that's not kind of a sustained solution to what's happening here. Many of these patients with significant overdoses, though, require much more advanced therapies. One of the big ones here is something called high-dose insulin euglycemic therapy, or HIET. And what this is, if you haven't done this or heard of this before, this might sound a little bizarre, but you start the patient on high-dose insulin. And what it actually does is it improves myocardial carbohydrate utilization, and that increases myocardial contractility. Bizarre to think about, but it's true. So high-dose insulin is almost like an inotrope. It improves myocardial contractility through kind of like supercharging the myocardium's ability to utilize carbohydrates. But this is high-dose insulin therapy. This is not to treat hyperglycemia. So these patients, and, again, none of this is tend to be acted upon as medical advice, double check doses and things like that. But typically you're bolusing something like 1 unit per kilogram. So this is a ton of insulin, 100 kilo person, it's 100 units, huge amounts. And then you're starting those patients on an infusion, usually 0.5 to 1 units per kilogram per hour. And you can even titrate that up. So these patients are getting huge amounts of insulin. And because of that, hypoglycemia is a really, really, really real risk, and it can kill patients. So you got to be incredibly, incredibly thoughtful about glucose checks, giving them dextrose back. You really want to maintain that glucose 100 to 250. Sometimes I err on the side of closer to 250 just to be safe, and they're gonna need a dextrose infusion. All right, they might need a high concentration dextrose infusion, not just D5 but D10 or D20. All right, you should be checking glucoses really every 15 or 30 minutes just because the hypoglycemia risk is so high. The other thing to always remember is insulin shifts potassium into the cell, right? So hypokalemia is a big risk of this. You want to keep that potassium greater than 3, people say, but really greater than 4 is a much better target. And they're going to need potassium supplementation. So if someone needs high-dose insulin to try to save their life from a calcium channel blocker overdose, they do. And many of these patients with bad overdoses will require this. But remember, this medication, this high-dose insulin euglycemic therapy, can also kill patients from hypoglycemia and hypokalemia. So we have to be very thoughtful in checking the potassium frequently, supplementing aggressively with potassium, and then also checking the glucose frequently and getting them on high-concentration glucose infusions as needed. So you've tried calcium, you've tried vasopressors, you've tried high-dose insulin euglycemic therapy. None of this is working. Adjunctive therapies that you can also give a shot are things like glucagon. Glucagon transiently can lead to more inotropy and chronotropy. This is more commonly used in beta blocker overdose. It probably has a limited effect in calcium channel blocker overdoses. It's not something we commonly use for calcium channel blockers, but you will read about it out there. Intralipid therapy. This is an option for refractory cases, especially if the calcium channel blocker is lipophilic. Philic meaning loving, lipo meaning fat, so fat loving. So intralipid therapy is essentially you give intravenous lipids, and if a medication is lipophilic, if it loves lipids, the intralipid will kind of encapsulate the medication in the bloodstream and lead it to not to be able to have its intended effect. So verapamil is a highly lipophilic calcium channel blocker. So patients who are failing initial therapy, if it is a lipophilic calcium channel blocker, you should give that patient intralipid therapy. And then patients just who have profound hypotension, refractory vasoplegia. People talk about the use of methylene blue. We've talked about methylene blue on the channel multiple times before, so definitely check out those episodes if you're interested in that. But methylene blue is something you consider in refractory vasoplegia. When all this is failing, the end-all be-all here is ECMO, extracorporeal membrane oxygenation, VA ECMO, another thing we've talked about on the channel. These patients, if they're sick enough, will require VA ECMO. You can do high-dose insulin therapy. You can do intralipid, methylene blue, vasopressors, calcium, all that stuff. And if the toxidrome is bad enough, if they've taken enough calcium channel blocker, they'll fail all that. And they'll have refractory shock, and they'll need ECMO. And most typically it has to be veno-arterial ECMO. Again, we've talked about ECMO on the channel. Check those out too. You just look up whiteboard medicine and ECMO and it'll pop right up. Same thing with methylene blue and all that other stuff. But these patients sometimes do need ECMO, and that's kind of the rescue therapy. That's where we get towards the end of the road. For refractory bradycardia, you can try temporary pacing. It's not always effective. You might have trouble capturing that beat, and you might have trouble getting capture, and thus you might not be able to pace them, but you can try, right? If a patient's going to die and you're doing everything you can certainly give that a try. So if we were just to summarize the therapies, right? So the first is stabilize, as you would any sick patient that's coming to the hospital. Decontaminate, considered activated charcoal as guided by poison center if it's a overdose that you got too quick enough. All right, IV calcium to see if you can overcome the blockade. Vasopressors like epinephrine and norepinephrine as needed. I'm going to put atropine in little parentheses because you can try it, but it's not a solution to what's going on and it might not work. High dose insulin euglycemic therapy. I'm going to put glucagon in parentheses because glucagon you can try, but it probably will not work. Intralipid be the next thing. Methylene blue for refractory vasoplegia. And then if we're getting down there at the end of the day, ECMO. So this is kind of the progression of therapies that you might see here. And this should be the things that you're thinking about, obviously as guided by a toxicology specialist or the poison center. So monitoring supportive care. All these patients with significant ingestions have to be admitted to the intensive care unit. Hopefully we've beat things over and over again and demonstrated, if nothing else, that these patients are incredibly sick and many of them die, so they all got to go to the ICU. Continuous cardiac and glucose monitoring, as one might imagine, serial electrolytes, serial glucoses, frequent hemodynamic assessments. All these patients should have an arterial line, at least in our humble opinion. And patients may require days of high-dose insulin therapy, of vasopressors, or even if they end up on something like ECMO. The prognosis for these patients is actually, unfortunately, quite poor for the sickest ones. Patients with refractory hypotension, severe acidosis, lactate greater than 8, requirement for ECMO. All these are very kind of poor prognostic signs. Survivors are often the ones who get aggressive early interventions. So don't sit there and kind of tolerate a little hypotension, a little bradycardia with the thought that your therapy is going to kick in, right? Be aggressive early on. Start these patients on calcium, start them on high-dose insulin therapy, give them intralipid, talk to ECMO specialists, all that kind of stuff. Aggressive early interventions are critical if we want to try to save these folks. All right. That's all we have for the main bulk of this episode. We have a quick reference we'll go through and then some practice questions at the end if anyone wants to stick around. Do remember that all these study guides are on our Patreon page, and we'd definitely love for you to check that out. It'll be linked in the description. But quick reference. So the classical clues for calcium channel blocker overdose are bradycardia, hypotension, and hyperglycemia. First-line therapies are IV calcium and vasopressors. Next definitive therapy is high-intensity insulin therapy, and start it early. Remember, early aggressive interventions are key. Adjuncts, you can trial glucagon, you can trial lipid emulsion, you could trial methylene blue, and rescue therapies are ECMO. Always talk to your poison control center. We put a number on here, although we can't guarantee that this is the right number, so actually maybe we'll cross that out. Just Google poison control center with your area, and you'll be able to find the number. So get them involved early. All right, now for some practice questions. The way we structure the practice questions is there will be a beginner, intermediate, advanced. We'll go through the question, we'll go through the possible answers, and then we'll have you pause if you want more time to think about it, because we'll dive right into the answer. So practice question number 1 for beginner. 60-year-old man, presents 2 hours after taking an overdose of his diltiazem tablets. He's hypotensive with a blood pressure of 85/50, bradycardic with a heart rate in the 40s, and he's lethargic. His glucose is 220. What is the best next step? A, start IV calcium. B, give naloxone. C, discharge home with observation. Or D, administer IV digoxin. Pause here if you need more time. The correct answer is A, IV calcium. We talked about how calcium is the initial stabilizing therapy. That's the first therapy you're going to be giving to these patients, assuming they don't need decontamination. So naloxone, option B, would be for opiate overdoses. Discharge home would be incredibly dangerous. As we talked about, these patients are very sick. And then administering IV digoxin, this is just a random wrong answer. Digoxin has nothing to do with calcium channel blocker overdoses. All right, question number 2, the intermediate question. A 45-year-old female ingested an unknown amount of amlodipine extended release. She presents 6 hours later with a heart rate of 55, blood pressure 70/40, despite IV fluids, glucose of 180, potassium of 3.5. She's received 2 doses of IV calcium with minimal improvement. What is the most appropriate next step? A, start high-dose insulin euglycemic therapy. B, administer glucagon infusion. C, increase IV fluids aggressively. Or D, discontinue monitoring if stable. All right, pause here if you need more time. The most appropriate next step would be A, start high-dose insulin euglycemic therapy. So we talked about these patients. You trial some fluids, trial some calcium, and if they have persistent shock, we got to be aggressive early. We got to put them on high-dose insulin therapy. Obviously, talking to your poison control center, but the most appropriate next step would be starting that high-dose insulin euglycemic therapy. Option B, administer glucagon infusion. I don't tend to do infusions, and for calcium channel blockers, this isn't that effective, so this would not be the most appropriate next step. This patient's sick. They need a high-dose insulin therapy and maybe even, a call to ECMO and vasopressors and all that jazz too. So that would not be the best answer. Increase IV fluids aggressively. This is not a hypovolemic problem. This is a vasoplegia and cardiac suppressant problem. This patient already received fluids. You're not going to save their smooth muscle relaxation and vasodilation or their decreased cardiac contractility with more fluid, so wouldn't be the best answer either. And then discontinue monitoring if stable, obviously just the wrong answer. So correct answer is A. Last question here, the advanced. A 38-year-old man is in refractory shock 12 hours after a massive verapamil ingestion. He's on norepinephrine at 0.5 micrograms per kilogram per minute and epinephrine at 0.3 micrograms per kilogram per minute, plus calcium, plus high-dose insulin euglycemic therapy at 8 units per kg per hour. Just to speak that out loud, if this person was 100 kilos, 8 units per kilogram per hour would be 800 units per hour. Huge numbers. His lactate's 10, his pH is 7.1, his MAP is 50. What is the best next option? A, add a third vasopressor. B, start IV lipid emulsion and evaluate for VA ECMO. C, stop the insulin therapy. D, administer a large sodium bicarbonate bolus. All right, pause here if you need more time. The correct answer is B. This patient, correct answer is B, start IV lipid emulsion and evaluate for VA ECMO. This patient has refractory shock despite maximal medical therapy. Lipid emulsion could help, but VA ECMO is the salvage therapy here, right? So other options, add a third vasopressor. You certainly can do this, but it would not be the next best step that would help save this patient. Option C, stop insulin therapy. Patient would most likely die. And option D, administer large sodium bicarbonate bolus, would not help this patient. They need ECMO and maybe lipid emulsion as salvage therapy. All right. That's all we have for you in this episode. Hopefully that was informative. Let us know what thoughts, comments, questions you have. Follow along, check out our Patreon page for practice questions, mini courses, study guides, every other day post just on general medical education content. We debrief on cases on there as well. We'd love to have you. We also have a podcast, YouTube members for early access to videos and ad-free videos and some exclusive content as well. And obviously we have this YouTube channel too. So we appreciate y'all. Hope everyone's doing well. Stay well, keep learning, and we'll see you next time. Hey everybody, and welcome back to another episode here with Whiteboard Medicine. We appreciate you checking it out. Hope everybody is doing well. We're coming off a stretch of night shift up in the medical intensive care unit. Luckily, we did not see any acetaminophen toxicity, which is what we're going to be talking about today, although we did have a beta blocker toxicity, which is a video for a future or in a topic for a future episode. So as one can see, we're going to be talking about acetaminophen toxicity or Tylenol toxicity today. This is a really important topic, a really critical topic, one that unfortunately is not uncommon. All right, we're going to be talking about what acetaminophen or Tylenol is, usual dosing. We'll talk about how common toxicity is, including the highest risk populations. We'll talk about the metabolism, both normal metabolism of acetaminophen and then the toxic metabolites that can cause toxicity. We'll talk about how to diagnose it. We'll talk about the Rumac-Matthew nomogram, antidotes including N-acetylcysteine, supportive care, liver failure, transplant prognosis, high-risk populations, all that good stuff. So this is going to be chock full of rich, hopefully nuggets and tidbits. We'll also sprinkle in some of our anecdotal experience. And at the end, we got a couple practice questions. So thanks for sticking around, and hopefully this is a high-value episode for you all. As a friendly reminder, none of this is intended to be acted upon as medical advice. Please check out the episode description or hang around till the end for the full disclaimer. No further ado, acetaminophen toxicity. Starting with what acetaminophen is. So as we've kind of implied already, the brand name in the States at least is Tylenol, but this is the brand name, so we'll be talking about the generic, which is acetaminophen. And acetaminophen, for those of you unaware, which probably is not many of you, is primarily an analgesic, so for pain, or an antipyretic for fever. So analgesic is pain, antipyretic is fever. And you can get it OTC, over the counter. You also can certainly get a prescription. There's certain combination prescription products combined with things like opiates, which might be brand name Norco, which is hydrocodone or acetaminophen. Our night shift brain is flailing. There's also things like Percocets. You can combine in cold and flu medications too, where it gets mixed with things like antitussive medications and other stuff. So there's lots of combination pills, and this is one of the reasons that toxicity can be so common, because folks don't often realize that there's acetaminophen in these combination pills, and then they're taking acetaminophen, they're taking the combination pills, and sometimes they actually get some degree of toxicity from that. So always check what is in the combination pills you're prescribing and certainly taking too. The usual dosing in an adult for acetaminophen is 325 milligrams to 1,000 milligrams per dose. Oftentimes the pills come in 325 milligram pills, but not every time. We've seen 500 milligram pills. I don't think we've seen 650, but maybe there's 650 milligram pills, but primarily we've seen 325 and 500 milligram pills. Now you can take up to 1,000 milligrams in a single dose, but the caveat to this is the maximal daily dose that we like folks to stay under is less than 4 grams of Tylenol per day. All right, some institutions actually say less than 3 grams, and there's certain populations where you should stick to less than 2 grams per day. So if you think about the dosing, anywhere from 325 milligrams to 1,000 milligrams per dose. If you're taking these higher doses, the 1,000, that's, just a couple doses a day would get you to that 2 or 3 or 4 gram per day max. Now, 4 grams per day or 3 grams per day is safe for the, quote unquote average person. But if you're on certain medications or have certain conditions, sometimes the recommendation is to stick to less than 2 grams per day. And that would be folks like chronic alcoholics, because they have some degree of underlying liver injury already. So if folks are daily drinkers or heavy drinkers, you have some kind of derangement in your ability to metabolize acetaminophen safely. So the recommendation is to take less than 2 grams total per day. People on different medications that are CYP inducers, CYP-CYP. This is an enzyme that can be involved in the metabolism of many drugs, but certain drugs can induce this. Antiepileptics like phenytoin or carbamazepine or phenobarbital or rifampin, which can sometimes be used to treat different infections. There's a whole list of them, but any of these, the recommendation is to have less than 2 grams of Tylenol per day, just because you have increased production, which we'll talk more about, of NAPQI, which is one of the toxic metabolites. So anyone on CYP inducers, take less. Anyone on medications that are hepatotoxic or toxic to the liver, things like isoniazid, valproic acid, methotrexate, all these can cause some degree of underlying liver stress. So adding acetaminophen on top of that can lead to additional liver stress, and that's why the recommendation is less than 2 grams per day in those folks too. Anyone with chronic liver disease, or folks on Coumadin actually, because the acetaminophen can potentiate the INR effect from Coumadin. So all of these folks, chronic alcoholics, patients on CYP-inducing medications, patients on direct hepatotoxic medications, patients with chronic liver disease, or on Coumadin, all should take less than 2 grams per day. Otherwise, the recommendation is either 3 or 4 grams per day total. So keep in mind combination pills, keep in mind the dose of acetaminophen you're taking, and keep in mind what chronic conditions might be out there or other medications that patients are on that might affect the safe maximal dose. In pediatrics, it's a little bit different. We're going to be focusing mostly on adults, but in pediatrics, it's 10 to 15 milligrams per kilogram every 4 to 6 hours, maximum of 75 milligrams per kilogram per day would be the recommendation. So why does this matter? Why are we starting by talking about dosing and maximal day doses per day and all that? Well, the reason is because overdose of acetaminophen, toxicity from acetaminophen, is actually the leading cause of acute liver failure in the USA and other higher income countries. And that's huge, right? Acute liver failure you can die from. Many people do die from it. Those that survive often can have chronic liver disease or sometimes even need a liver transplant. So this is an incredibly morbid condition, and it's one that unfortunately is not uncommon. So epidemiology and risk factors for acetaminophen toxicity. Well, a couple stats just to further frame the conversation here. And one of those stats is that acetaminophen toxicity accounts for 40 to 50% of acute liver failure cases in the USA. All right, intentional self-harm as well as unintentional repeated exposure to higher levels of acetaminophen all contribute to acute liver failure. So this is almost half of the acute liver failure cases in the USA are from acetaminophen toxicity, either intentional self-harm or unintentional repeated supratherapeutic dosing. Risk factors for toxicity at lower doses are the things we talked about, right? The things that should keep a patient to take less than 2 grams per day total: chronic alcohol use, malnutrition, chronic illness, enzyme-inducing drugs, right? We talked about rifampin and carbamazepine and phenytoin, underlying liver disease, right? All these things are why the max in that patient population is less than 2 grams per day rather than the less than 3 or 4 grams per day. And then the combination products, just to drive this point home, combination products of acetaminophen and something else, again, often opiates, are common culprits for toxicity because folks don't realize that there's acetaminophen in those combination products. So how does acetaminophen cause toxicity? What is the pathophysiology, the mechanism at play? Well, to understand that, we have to start by understanding the normal metabolism of acetaminophen. Okay, so the normal metabolism, and we'll go through kind of the pathway again, but we're just going to read it out to start, involves glucuronidation and sulfation. This is a way to metabolize a drug, to take the drug and break it down into its non-active forms. And glucuronidation and sulfation are around 95% of all metabolism for acetaminophen. So this is the vast majority of the acetaminophen is metabolized using glucuronidation or sulfation. And when it's metabolized this way, it creates a non-toxic metabolite. And this non-toxic metabolite you just excrete out, you just get rid of it, no issue at all. The challenge with toxicity is that a smaller amount of acetaminophen is not metabolized through this glucuronidation and sulfation. It's metabolized by something called the CYP2E1. This is an enzyme that the body has that metabolizes drugs. And about 5 to 10% of acetaminophen, even in the normal metabolic pathway, goes through the CYP2E1 enzyme. And that actually produces something called NAPQI, N-A-P-Q-I. Okay, and this is a toxic intermediate. So this is acetaminophen, you ingest it, 90 to 95% of it gets glucuronidated or sulfated, and it's just excreted in a non-toxic form. But even in someone healthy with normal acetaminophen metabolism, 5 to 10% goes through the CYP2E1 pathway, and it gets broken down into NAPQI, which is a toxic intermediate. But in most people, this NAPQI is detoxified by something called glutathione. All right, this is, getting a little confusing, so let's keep track of it. Normal metabolism, glucuronidation, and sulfation. Non-toxic metabolite excreted out. Normal metabolism, a small percent, 5 to 10%, gets CYP2E1. Acetaminophen is metabolized through the CYP2E1 pathway into NAPQI, a toxic metabolite, but in folks who with the normal metabolism who did not take too much of the drug, that toxic metabolite, NAPQI, is detoxified by glutathione, and that's just then detoxified into a non-toxic additional metabolite that's excreted out. Where we run into problems is in overdoses or in folks who took too much. Because this pathway, this glutathione pathway that detoxifies the toxic metabolite NAPQI, gets saturated, gets overworked. There's only so much of it in the body. And that leads to accumulation of NAPQI. And when then that NAPQI accumulates, it causes hepatic necrosis or liver injury. It also causes some mitochondrial injury. But all this then leads to liver injury. AST and ALT, our liver enzymes, get elevated. Our blood starts to get coagulopathic, we get encephalopathic, and we can go into multi-organ failure. And this can lead to acute liver failure, which can lead to death even. So what happens in toxicity is the CYP2E that breaks down the acetaminophen into NAPQI, the NAPQI, which then should be detoxified with glutathione, there's just too much of NAPQI, right? Because we took too much acetaminophen. So we don't have enough glutathione to detoxify it all, and that NAPQI builds up and leads to liver injury. Okay? So this usually takes, if we deplete more than 70% of our glutathione stores, that's when we start to see liver necrosis, liver injury from the NAPQI that's building up. If we look at this in a larger pathway form, and if you're listening to this in podcast version, apologies, we'll try to describe the figure we have here. But what it essentially is you take acetaminophen, right? You take Tylenol. And the two non-toxic pathways that the Tylenol is metabolized through is glucuronidation and sulfation. And that creates these non-toxic metabolites that are just excreted. Right, and this is about 90 to 95% of your acetaminophen goes into these non-toxic metabolic pathways. But you get CYP2E1, about 5 to 10% of the Tylenol you take is metabolized through the CYP2E1 pathway into NAPQI, which is toxic. But in a normal person, there's not a ton of that NAPQI, and our glutathione detoxifies it into a non-toxic second metabolite, cysteine, mercapturic acid, all that stuff, and then it's just excreted. But when we overwhelm this glutathione pathway, when we deplete more than 70% of it, we start to get a buildup of NAPQI, and that NAPQI, when it builds up, can cause direct liver injury. And if that liver injury gets too bad, it leads to liver necrosis. When the liver stops working, we get transaminitis, coagulopathy, altered mental status, encephalopathy. It can even lead to lactic acidosis, renal injury, and even death. All right? So this will then play into our treatment, because essentially what we do when we treat it is we give N-acetylcysteine or NAC, which increases the amount of glutathione we have, which allows us to detoxify more of that NAPQI. But we'll talk more about that. All right, this figure is a nice Wikimedia figure, but it's a good figure. But we put the link there because it's theirs, not ours. So clinical course, what do you actually see clinically? We kind of understand the pathophys now. We understand what's happening when we take too much acetaminophen and you get buildup of that NAPQI and we don't have enough glutathione to detoxify it. Sorry, had to wet our whistle. And then we talk about the normal metabolic pathways, but what are we actually seeing clinically? What are we seeing bedside? You know, how does this progress? What are patients experiencing? Well, there's 4 stages of acetaminophen toxicity, and this is really important, and you will see this. Stage 1 is 0 to 24 hours, so pretty much day 1. And this is mostly GI symptoms, nausea, vomiting. You know, you might get sweaty, you might get a little pale. And at this point, the interesting part is your labs might be normal. You might not yet have the transaminitis or coagulopathy. So patients come in mostly with GI symptoms. And that's tough, right? A lot of things can cause GI symptoms. But it's important to ask, have you been taking medications? Yes, I have. What medications have you been taking? Acetaminophen. How much have you been taking? You know, X, Y, Z. So it's important to screen for toxicity of acetaminophen in folks with GI symptoms, because obviously it's very nonspecific. But that's stage 1, 0 to 24 hours. Stage 2 is then 24 to 72 hours, or 1 to 3 days. And this is when folks start to get sick. You start to get more focal abdominal pain in that right upper quadrant. Why the right upper quadrant? Because that's where your liver is, in the right upper quadrant. All right, your liver starts to swell. It starts to stretch your liver capsule and cause pain. You then start to get your transaminitis, which is rising liver function tests, an increase in your ALT, your AST, your bilirubin goes up. This stage 2 is when you might start to get coagulopathic. Your INR might start to prolong. And the GI symptoms sometimes actually improve. They sometimes actually get better, other than the pain, with the nausea, vomiting, and all that. But this is where patients start to manifest with lab work that shows that they're getting really sick. And if this goes untreated, it can progress to stage 3. And this is the stage where people can die. This is 72 to 96 hours, or, day 3 to 4. And this is when we get peak hepatotoxicity. All right, folks might get jaundice. They might turn yellow in color. They get severely coagulopathic, so that INR and PT and PTT skyrocket. Your liver is involved in glucose regulation, so you start to get hypoglycemia, or your glucose drops because your liver can't regulate your glucose levels. You get a high lactic acidosis. You get acute kidney injury, AKI. You get encephalopathic and confused, and your liver function tests, your AST and ALT, skyrocket, usually multiple thousands, right? Sometimes as high as double-digit thousands. And if this is not intervened on, and even if it is, if it's not intervened early enough, this can lead to death. This is the stage where people can die from profound liver failure, leading to multi-organ failure and death, right? So this is day 3, 4, all right? Stage 4 is 4 days up to 2 weeks, and this is recovery. If you make it through stage 3, you tend to get recovery. You tend to get complete liver regeneration. Sometimes you have a little residual liver injury, but the liver's hardy. If you can get it to stage 4 without complete liver failure, sometimes you can get hepatic regeneration. In survivors, labs often normalize over several weeks. But again, if you don't start to recover, so if stage 3 does not go to stage 4, you do need liver transplant or you can die. So just to say it out loud, stage 1, I like to think of it, it's day 1. Stage 1 is day 1, 0 to 24 hours, non-specific GI symptoms. Labs might be normal. Stage 2 is days 1 through 3. And this is where labs start to become deranged. Stage 3 is 3 to 4 days. And this is where you can die. This is where you go into liver failure. If you make it to stage 4, though, this is where you start to get recovery. If you don't make it to stage 4 and your stage 3 just keeps worsening, you might need a liver transplant. So these are well-described stages. They will be clinically apparent. This is what it happens. And this is really important to kind of keep in mind. That patient who took too much acetaminophen who comes in 4 hours afterwards in stage 1, they might look relatively okay, have some nausea, vomiting, their labs not be terrible. So it can give you this false sense of reassurance. But you really have to have a high index of suspicion. You have to intervene early and aggressively to try to prevent stage 3 from getting worse to the point where their liver fails. So what is the initial ED and ICU approach, the initial management algorithm? Well, like anything with sick patients, primary survey. Make sure they're protecting their airway. Treat for hypoglycemia. Treat for shock. So this is a kind of aggressive supportive care like we do for all of our critically ill patients, trying to address the things that are going to kill the patient first. When we're talking to these patients, though, if they're able to talk, or family members, history can be really key. And the questions that are really key is the time of ingestion. This can be incredibly important, which we'll talk about in a second, to look at this Matthew nomogram. So time of ingestion is important. Sometimes this is really simple. Sometimes it's, I took a whole bottle of Tylenol at this time. Sometimes it's more complex, right? Someone's like, well, I've been taking this much Tylenol every day for the last 3 weeks, but then this day I took a little bit more, and I don't really know the time of ingestion. But if you can pin down a time, critically important. The amount makes sense, right? How much Tylenol you took is super important as well. This can sometimes just be a complete indicator that the patient is going to get really sick. They need N-acetylcysteine. They're at risk for liver failure. You maybe even should transfer them to a liver center if you aren't one for some of these massive ingestions. So the amount can be important. Product, either immediate release versus extended release. This is critical too, and I think sometimes we forget to kind of ask or look into this, because extended release, the timeline is going to obviously be much different than intermediate release. Co-ingestions are important too. One, to see if you should be expecting toxicity from any other ingestions, and two, sometimes co-ingestions change the timeline in which the drug is metabolized. It sometimes even changes your gastric emptying, right? If you take something, co-ingest something that slows your gastric emptying, that might mean you're going to reabsorb things later on. So co-ingestion is important. Obviously, intent, was it intentional to commit suicide? Was it unintentional? And then risk factors. Do folks have risk factors to get worsening liver injury, right? Maybe they're a drinker, maybe they already have liver disease, those types of things. But the big things that you're always asking about, and this is really for most tox cases, are time, amount, intermediate versus extended release, and co-ingestions. All right? Maybe we'll think of it like TARC, time, amount, release, co-ingestions. Kind of like that. Just made that up right now. TARC. Cool. Okay, immediate actions after the primary survey and some history keeping. If the timeline says they're less than 4 hours from ingestion, this is kind of this magical number we're going to talk about that isn't really magical, but is important. If they're less than 4 hours from ingestion, they say, I drank this whole bottle of acetaminophen and I came right into the emergency department, it was just an hour ago. Consider activated charcoal, right? This is 1 gram per kilogram, although this is not medical advice, so always look up your dosing, max of 50 grams. This is if they have a protected airway, because this can cause vomiting and things. So they have to be awake and protecting their airway. You shouldn't try to be shoving this down someone's throat who's minimally responsive. An extended release product, sometimes it'll help up to 8 hours from ingestion, but if it's less than 4 hours, you really should consider activated charcoal, okay? That can help slow absorption and decrease the maximal serum levels that are gonna happen. Okay, so immediate actions less than 4 hours, consider activated charcoal. Get your labs, right? Get a Tylenol level. Get your liver function test. Get coags. Get a metabolic panel, glucose, lactate, blood gas. Ammonia is not unreasonable. If they're female, get a pregnancy test. Look for co-ingestions with an ethanol level, salicylate level. Sometimes a urinary tox screen, but this is a little question mark E. Lots of negatives here. Probably could be a topic for a whole separate video. And then when in doubt, when the timeline is in doubt, so they're like, I don't know when I took it, or maybe they won't tell you when they took it, or maybe they don't know, or maybe they're not very responsive. Or if it was 8 hours from ingestion, just start N-acetylcysteine immediately. And we'll talk more about N-acetylcysteine and NAC coming up here, but this is the antidote. And the reason that you don't start it on everybody necessarily is because some folks won't get to a high enough serum level where they need N-acetylcysteine. But N-acetylcysteine is life-saving in patients who have acetaminophen toxicity. This can save their life, and it's a relatively safe drug. So when in doubt, give it, okay? Don't hold back, just give it. All right, what is this nomogram people talk about, the Rumack-Matthew nomogram? This is classic discussion every time people talk about acetaminophen toxicity. And it's a nomogram that maps out the Tylenol level compared to the time from ingestion to help give an idea on if they need treatment or not. So again, this is not our figure. We appreciate the use of it. And this is essentially a figure that looks at hours from ingestion. So you need a timeline here. And that's why when in doubt, if you can't get a timeline, you just give N-acetylcysteine. So this is on the x-axis, hours from ingestion. On the y-axis, Tylenol plasma concentration. So you obviously need a Tylenol level for this. And then it looks at the Tylenol level from time from concentration. And if you're above the line, you should be treating with N-acetylcysteine. If you're below the line, you don't necessarily have to treat with N-acetylcysteine, okay? So treatment should be administered if levels above this solid line. So at 4 hours, that's when it starts. 4 hours post-ingestion, this is your first kind of marker here, right? So if you're above 150, I know it's a little small, if you're above 150, if your Tylenol level is above 150 at 4 hours, give NAC. And then there's an 8-hour, 12-hour, 16-hour, all that. So if someone's like, I ingested my Tylenol 7 hours ago, and then you look on the Rumack-Matthew nomogram, you go to the 7-hour mark. This says, I can't quite see, but it says something like 80. If your Tylenol level is above 80 at 7 hours, give NAC. If it's below 80, you can monitor it. Now, there are some exceptions to this that we'll talk about, and you obviously need a good timeline for this, but the oh, no, my drawing pad might die. But if you're above this level, this is really important to treat with NAC. Okay, let's continue moving on, and we'll talk about this in more detail. So this nomogram is not useful, okay, not useful if the Tylenol ingestion is more than 150 milligrams per kilogram per day. So if we just say someone's 100 kilograms, just to give an idea, 150 times 100, hopefully I don't do math wrong, but I think that's 15,000 milligrams in a day, okay? Just for a 100 kilogram person. Obviously someone smaller than that, 50 kilograms, if I did my math right the first time, that's 7,500 milligrams per day. And we said doses are 350 to 1,000 milligrams. So this is not a ton of pills. It's a lot, but it's not a ton, especially if someone is smaller. So if someone took more than 150 milligrams per kilogram per day, then you just treat with NAC, okay? If someone has been taking more than 4 grams per day for more than a couple of days, you just treat with NAC. Or if anyone has elevated liver function tests, you just treat with NAC. So the nomogram is not useful for any of these patient populations. Obviously, we also talked about if you don't know the timeline, if there's a doubt on the timeline, if it was more than 8 hours ago, just treat with NAC. When in doubt, treat with NAC. Poison control, big shout out to poison control here. You can Google it. You can Google poison control's number, call them. They are a great resource. You should be calling the poison control, at least in the United States, can't speak for other countries, but you should be calling poison control for all of these patients. All right, antidote therapy, let's dive more into it. We've been talking about NAC or N-acetylcysteine for a little bit now, but why does NAC work? All right, it replenishes the glutathione. And if you remember, we said that acetaminophen, we'll abbreviate it APAP, most of it gets metabolized, 95%, through glucuronidation or sulfation, but then 5% gets metabolized through the CYP pathway into NAPQI. NAPQI, we said, is toxic, but our glutathione usually sweeps in and detoxifies it. But if we overdose on it, we don't have enough glutathione, so NAPQI builds up and causes hepatotoxicity. But what N-acetylcysteine does is it replenishes the glutathione. So if you give N-acetylcysteine, this glutathione gets replenished, so then you are able to detoxify more NAPQI and decrease the amount of hepatotoxicity. All right, it also enhances conjugation, it detoxifies NAPQI. Timing is best if it's less than 8 hours from ingestion, but it's still indicated later. All right, so again, get this started early, be aggressive with it. It can save people's lives. Dosing, again, not medical advice, so definitely confirm all these, but IV N-acetylcysteine versus oral N-acetylcysteine. We often do IV. Oral can make people really nauseous. Folks don't like it, but IV, you usually give a kind of first bolus over 60 minutes, 150 milligrams per kilogram. You then usually get 15 milligrams per kilogram over 4 hours and 100 milligrams per kilogram over the next 16 hours. Again, this is a 21-hour protocol. Watch for anaphylactoid reactions. This can happen. It's not common, but it's common enough to definitely be mindful of it. Otherwise, N-acetylcysteine NAC is a fairly safe drug. Continue N-acetylcysteine until the Tylenol level is undetectable, the acetaminophen level. Liver function tests are improving, and your INR comes down. All right. So supportive care and monitoring. What you're going to support and monitor are going to be related to the toxicity the acetaminophen causes. So you want to monitor labs at least every 12 hours, but sometimes even more than that. And then you want to watch for all these complications: hypoglycemia, coagulopathy, encephalopathy, acute kidney injury. If it was an intentional overdose, obviously you need to address the reason for the intentional overdose with psychiatric support too. But you want to watch for all these complications. Sometimes lactic acidosis as well you want to monitor for. Obviously you're trending your liver function tests as well, watching their hemodynamics, all that stuff. So these patients can get really, really sick and require lots of monitoring, and sometimes require that monitoring to be in the intensive care unit if the ingestion was significant enough. So special populations that you need to be aware of. Those that took extended release products, we've talked about this a couple times because this just makes things very complicated, right? The nomogram doesn't work. You don't necessarily know when their peak effect is going to be because they get a delayed peak because they have extended release. So our suggestion is to have a very low threshold to give these patients NAC, independent of all the other stuff because they took extended release products. Chronic alcohol use or malnutrition, patients are higher risk to go into liver failure, so just know that. If you have a patient who has acetaminophen toxicity with chronic alcohol use or malnutrition. Pregnancy is obviously a really tough one. N-acetylcysteine is usually considered fairly safe, but again, verify that. Pediatrics, things become weight-based, and then unknown time from ingestion can make things really challenging too. But again, when in doubt, knock it out. Give them NAC, give them N-acetylcysteine. So acute liver failure and transplant. We just wanted to shout out the King's College criteria. So as we've mentioned, patients who have acute liver failure from acetaminophen toxicity, many of them need transplant. But how do we predict those that might need a transplant? If you aren't at a liver transplant center, how do you know who you should transfer there? Well, those that need an early transplant referral, the King's College criteria from London, from King's College, studied it and found that anyone with an arterial pH of less than 7.3 or INR greater than 6.5, creatinine greater than 3.4, and grade 3 to 4 hepatic encephalopathy, or severe lactic acidosis. So these are all or statements. So anyone who's acidemic, anyone with severe lactic acidosis, or anyone with severe coagulopathy, acute kidney injury, and hepatic encephalopathy should all get early transplant referral. And this can be critical. This can be life-saving. This might be the only therapeutic option the patient has to save their life, liver transplant. All right, prognosis. Prognosis is excellent if N-acetylcysteine is started within 8 hours. Again, that N-acetylcysteine replenishes the glutathione stores. That glutathione then detoxifies the NAPQI, and then you don't have that NAPQI circulating around to cause liver injury. So NAC within 8 hours, prognosis is excellent. If the patient is in acute liver failure at presentation, the prognosis can be really poor, right? That's a patient that needs a liver transplant. Think about those King's College criteria. All right, we're coming to the end now. Just quick reference guide, and then we'll do some practice questions. So quick reference guide, remember toxic doses in adults are greater than 150 milligrams per kilogram or greater than 7.5 grams for kind of a quick cheat. So keep that number in mind. If the 4-hour level in someone who did not take co-ingestions, took only immediate release, and has a really defined timeline, if that 4-hour level is greater than 150, treat. Let's get this out of here. Treat with N-acetylcysteine. But remember, you can't depend on this level on the Rumac-Matthew nomogram if they took extended release or co-ingestions or the timeline's unclear, it's chronic, or what have you. So when in doubt, treat. But in someone who you kind of have a good timeline, it's all immediate release, you can use this nomogram to help guide when to initiate NAC therapy. If their ingestion is within 4 hours, consider activated charcoal, and then always, 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 always call the poison center. All right, let's do a couple practice questions here. It's going to be, first one's going to be beginner, second intermediate, and third advanced. The way we'll do it is we'll read the question stem and answers, then we'll pause quickly, and then we'll talk about the answer. So if you need more time to think, just pause after we go through the answer options, and then just replay when you're ready to hear the answer. So question number 1 for beginners. 22-year-old female presents 3 hours after ingesting 15 extra strength acetaminophen tablets, 500 milligrams each. She's alert, mildly nauseated, has stable vitals. What is the next step? A, discharge with reassurance. B, send acetaminophen level immediately and await results. C, administer activated charcoal and obtain an acetaminophen level at 4 hours. Or D, start IV and acetylcysteine immediately. All right, pause here if you need more time. The answer is C, give activated charcoal and get a 4-hour level. No need to start N-acetylcysteine yet if less than 4 hours. So the keys here are 1, 3 hours from ingestion, okay? So we don't need a level until the 4-hour mark. So we have a good timeline. It's 3 hours from ingestion. 15 extra strength, so we know the amount and the dose. And we know that 15 times 500, we'll probably do our math wrong, but it's about 7,500 maybe milligrams. So it's not quite above that for sure toxic dose. And then vitals are stable. So do we need a discharge reassurance? No, this was a significant ingestion. We don't want to discharge. Do we send a Tylenol level immediately and await the results? You don't, because a 3-hour Tylenol level, if you remember, that Rumac Matthew nomogram starts at 4 hours. So you wouldn't know what to do with a 3-hour level. If it's within 4 hours of ingestion, you can try activated charcoal, so that makes sense. And then obtain an acetaminophen level at 4 hours, so that makes sense too. That's when the nomogram starts. Start IV N-acetylcysteine immediately. You would not be wrong doing this necessarily because you're kind of at the 7,500 milligram amount, but it's not above that, and you also could get a 4-hour level and wait. But this is not the best answer. D, start IV N-acetylcysteine immediately, but it's not a horrible answer. But it's not the best answer. The best answer is to administer activated charcoal and obtain acetaminophen level at 4 hours. All right, intermediate level question. A 34-year-old man with chronic alcohol use presents 16 hours after ingestion of acetaminophen. Their AST is 800, ALT is 900, INR is 1.7, acetaminophen level is 22. What is the best management? A, no treatment needed. B, start IV N-acetylcysteine. C, discharge with follow-up. D, immediate transplant evaluation. All right, pause here if you need more time. The answer is B. Start IV N-acetylcysteine immediately. So this is a late ingestion, and we don't necessarily know what the formulary that they took are. They also have chronic alcohol use, so you want to treat with N-acetylcysteine despite low acetaminophen levels for a couple reasons. So the keys here are 16 hours after ingestion, okay? So they are way beyond the acute phase. They have elevated liver function tests, right? They have an elevated AST and ALT. They have chronic alcohol use, so they're higher risk. And they still have acetaminophen in their system at 16 hours. So because of the elevated LFTs in particular, you're going to start N-acetylcysteine immediately. You definitely want to treat. You definitely don't want to discharge. And the immediate transplant evaluation, we tend to use those King's College criteria. And we don't have all the data in this question stem, but this would be a pH of less than 7.3, right? This would be an increased lactic acid, or an INR that's high, acute kidney injury, and hepatic encephalopathy. So he doesn't quite meet any of these, so he doesn't need an immediate transplant evaluation, but you should be starting N-acetylcysteine. All right, last question, advanced. A 50-year-old female, 24 hours post-ingestion, arrives confused, jaundiced, tachycardic. Labs have a pH of 7.28, a lactate of 6, AST of 5,200, INR of 7, and creatinine of 3.8. What is the best next step? A, supportive care. B, stop N-acetylcysteine. C, continue N-acetylcysteine and initiate urgent transplant evaluation. Or D, immediate dialysis without N-acetylcysteine. Pause here if you need more time. We kind of talked about this in the last question. The answer is C, which is continue N-acetylcysteine and initiate urgent transplant evaluation. So the key here is that this patient meets those King's College criteria, right? They actually meet multiple of them. They meet the one that is pH of less than 7.3, because this patient's pH was 7.28. They meet the one that is elevated lactic acid, because this patient's lactate was 6. And they meet the one that was INR greater than 6.5, creatinine that's elevated, I can't remember the exact amount, and then hepatic encephalopathy because they're confused. So they actually meet all the King's College criteria. You obviously want to continue the N-acetylcysteine, but you want to transplant or refer them to a transplant referral center as soon as you possibly can, because they might need a liver transplant to save their life. All right, that's all we have for you today. We appreciate you checking out the episode. Remember, we do have a High Yield Patreon page with this study guide as well as practice questions linked in the episode description. We also have a podcast in this YouTube channel as well, depending on if you're either listening to this or watching this. So we'd appreciate you checking those out too. We'd love for you to join any of those. We appreciate you all. Let us know what thoughts, comments, questions you have. And either way, stay well and keep learning. Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day today. Today's topic is going to be one central to emergency critical care medicine, and that is salicylate toxicity. This is toxicity that comes from overconsumption of salicylates, aspirin being probably the most common one, but there's a number of different products that have salicylates in them, and it creates a really interesting and unfortunately quite significant way that can make people really sick pathophysiology that results from it. So we're going to dive into all things salicylate toxicity today. We'll talk about what it is, symptoms, signs, pathophysiology, diagnosis, management, unique circumstances. And then at the end of the episode, we'll have practice questions and kind of some high-yield board review as well for those who, are watching the episode to get a grasp on salicylate toxicity from a board review standpoint. But there will certainly be lots of bedside nuggets too. So no further ado, let's dive into salicylate toxicity. So why does this matter? Why are we talking about it today? If you're familiar with the channel, you know that we've talked about beta blocker toxicity and calcium channel blocker toxicity and acetaminophen and some pathomimetics and a whole bunch of other stuff. If you're interested in any of those episodes, just search Whiteboard Medicine, followed by, whichever one of those episodes you're interested in. So we've talked about a bunch of different toxidromes, but why salicylate? Why now? Well, salicylate poisoning is one of the kind of classic toxicologic emergencies. See in the emergency department, certainly see in the ICU, and these patients can deteriorate quite rapidly, even when they might have some reassuring vital signs and laboratory values initially. And that is critical, right? You don't want to be falsely reassured based on the initial presentation, because these patients can decompensate quite quickly. Severe toxicity can cause mixed acid-base derangements. This is classic salicylate toxicity stuff that we'll talk more about. Neurotoxicity, pulmonary edema, hyperthermia, and cardiovascular collapse, right? All these things we're going to dive into more as the episode progresses, but all these are really severe. Many of them can end up being fatal if they're not appropriately managed. And we should say, if anyone is interested in this study guide, this PDF that we are going through in this episode, all of them are available on our Patreon page. If you don't know our Patreon page, we have been working really hard to build an emergency critical care medicine Patreon community, and we've had a ton of great feedback from people. The community is growing like mad, which we're so excited for, and we have every PDF or study guide from all of our episodes. We also have mini courses, we have ad-free videos, clinical reviews, practice questions, medical education posts. It's probably one of the larger emergency critical care educational collections out there and available, with kind of full comprehensive emergency critical care and ICU curriculum stuff. So definitely check that out, linked in the episode description, as well as the pinned comment if you're watching this on YouTube. Okay, enough of that. Salicylate toxicity, the most dangerous mistake is failure to recognize especially worsening CNS salicylate penetration. This is a key concept, and if you're unfamiliar with what we're referring to, that means that we got plenty to learn in this episode. So patients can appear deceptively stable until they suddenly decompensate. Let's start by talking about common sources of salicylates. Where can patients either intentionally or unintentionally consume too much salicylate? Well, the first and the main one, as we mentioned, is aspirin. This is the most common salicylate that is consumed. It's the most common cause of salicylate toxicity is overconsumption of aspirin, again, whether intentional or unintentional. Another one, and these ones are sometimes formulations that people and patients don't necessarily know contain salicylates. One is oil of wintergreen. This is very concentrated salicylate. You have to be incredibly careful with this. 1 teaspoon of oil of wintergreen has around 7 grams of salicylate. This can be lethal. This can be deadly. You can die from consuming this. So this is a huge one to look out for. And then other sources you might not think about are bismuth subsalicylate. Not that brand names are what we put forward here. We always try to stick with generics, but Pepto-Bismol would have some bismuth in it. Topical salicylates, you do absorb portions of topical salicylates, some herbal products, combination of cold medications. And this is a really important one, right? For these unintentional salicylate toxicities, it usually involves polypharmacy. Maybe a patient took aspirin and knew that aspirin had salicylate, but maybe they also took Pepto, didn't realize that had salicylates. They used some topical salicylates as well, didn't realize that, and then they took some cold medication for whatever reason, right? This might be a concoction that could cause toxicity, but a patient may not have realized that all these formulations had salicylates in them. So it's a good rule in general, right? Polypharmacy and unintentional consumption of compound formularies that contain salicylates in them is a cause of salicylate toxicity that can sometimes fly under the radar because patients don't come in and say, I took too much aspirin. They come in with symptoms and don't realize those symptoms are secondary to a combination of medications that they were on. So toxic dose overview, we want to go through kind of approximate milligrams per kilogram of salicylates that can cause toxicity. Know, though, just like everything in this episode and on our channel, none of this is intended to be acted upon as medical advice. This is all educational. This is not a hard and fast rule, but maybe from an educational standpoint, it'll give a baseline. So if you have less than 150 milligrams per kilogram of salicylates, you can get minimum toxicity, but usually minimal. Anything above that, right, 150 to 300 milligrams per kilogram can cause mild to moderate toxicity, 300 milligrams per kilogram to 500, severe toxicity, and more than 500 milligrams per kilogram, this can potentially be lethal. So if we think of it from that standpoint, it's really important that we keep track of the dosing of salicylates that's being consumed. And when a patient comes in with potential salicylate toxicity, you can ask them. Sometimes they know. Certainly, trust but verify. So you shouldn't put all your money in that single bucket based on what the patient said. But if the patient said, I took, let's just try to make it easy, aspirins that are 300 milligrams, and they say that I took 10 of these, that's 3,000 milligrams, right? And that's 3 grams of aspirin. Now, if the patient only weighs, let's say 50 kilos, 50 kilograms, so 50 3,000 divided by 50, we should really stop doing math on the channel, but this would be a minimal toxicity probably. Now, if they said I took 300 milligrams aspirin, now we're talking about 30,000 milligrams or 30 grams. Again, we won't try to do math again, but this could potentially be a significant toxicity. So ask the patient. Sometimes they know, sometimes they don't. You should never fully trust that reporting, but it can sometimes put things in the ballpark for you. Do note, though, that the clinical status of the patient matters a lot more than the serum level. And we'll get into serum levels a little more as we progress. But just because a level in the blood is a certain level does not necessarily mean the patient is having severe or mild toxicity. Clinical status, the patient's signs and symptoms, are much more important when talking about severity of ingestion. Pathophysiology. This is where salicylate toxicity gets really interesting, at least if you're a big nerd like we are. So salicylate toxicity produces a unique combination of pathophysiologic derangements, right? It affects the respiratory system, metabolic system, neurologic system, thermoregulatory system. All can become deranged. And understanding this physiology is critical because it drives a lot of our management decisions. It certainly helps explain a lot of the symptoms and signs you might be seeing as well when you're evaluating these patients. So the body, when you have salicylate toxicity, compensates, and these compensatory mechanisms can sometimes be life-preserving. So understanding the compensatory mechanisms are important too, and that's what we're going to dive into. So the first thing we wanted to talk about, we're going to take a swig of water here, keep the throat fresh. Apologies. The first thing we want to talk about was direct respiratory center stimulation. And what we're talking about here is salicylates actually directly stimulate the medullary respiratory center. And this causes the initial tachypnea, hyperventilation, and respiratory alkalosis, because as your respiratory rate increases, your amount of dissolved CO2 in your blood, your PCO2, decreases, and that leads to a respiratory alkalosis. And this is one of the first parts of the complex acid-base disturbances that can occur, a respiratory alkalosis, because that salicylate is directly stimulating your medullary respiratory center. This often leads to the earliest physiologic abnormality. Patients may present with deep, rapid breathing, low carbon dioxide levels, and an elevated pH, right, alkalosis. And this hyperventilation is often actually protective, not pathologic. And why it is protected? And we're going to get way more into this. So if this doesn't register right away, there will be ample opportunity for us to talk more about it. But the respiratory alkalosis actually helps to keep salicylates ionized. If they're ionized, they have less CNS penetration, and it can delay worsening toxicity. One of the therapeutic measures we're going to talk about is actually alkalizing the blood and urine, right? Giving bicarbonate. So again, we're skipping ahead a little bit, but that respiratory alkalosis actually can help protect the patient from some of the really severe sequelae of salicylate toxicity. So respiratory alkalosis. symptom number one. Pathophysiologic principle number one. Pathophysiologic principle number two, uncoupling of oxidative phosphorylation. It sounds as bad as it is. This is one of the most important mechanisms in severe toxicity. So normally, a person, the mitochondrial electron transport chain generates ATP. This is an efficient process. It's kind of the highest energy yield process. This is how we all survive, how we all make ATP. This is critically important. People cannot survive for prolonged periods of time without functioning mitochondrial electron transport chains generating ATP. Salicylates, though, disrupt this process, and they do it by uncoupling oxidative phosphorylation. So essentially, the mitochondria's electron transport chains need to have oxidative phosphorylation to produce ATP. So salicylates uncouple this process and make it so we can't effectively have oxidative phosphorylation. As a result of that, ATP production decreases, right? ATP is energy. So without ATP, the body starts to not be able to function adequately. You also start to generate a lot of heat. The body gets very warm, and you start to consume huge amounts of oxygen because you're not able to utilize that effectively. This leads to hyperthermia, increased metabolic demand, lactic acidosis. This lactic acidosis is because you have to start doing anaerobic metabolism because, again, you cannot effectively use your electron transport chains. So anaerobic metabolism causes a lactic acidosis, and cellular energy failure. Your ATP levels are going to go way, way down, and this can be fatal if it gets bad enough, right? So uncoupling oxidative phosphorylation. Patients essentially enter a hypermetabolic state. Pathophysiologic principle number three, and this is connected to the previous one. You start to get increased anaerobic metabolism and organic acid production. So as ATP generation becomes inefficient, right, because we have uncoupled that electron transport chain in our mitochondria, so we're not able to effectively create ATP. Cells shift towards anaerobic metabolism, as we mentioned. That anaerobic metabolism starts to generate lactate. You also start to generate keto acids because without effective ATP production, you start to break down more fatty acids into ketones, and those ketones are acidic. So you get keto acids and other organic acids. This then drives the next part of the acid-base disturbance, which is an elevated anion gap metabolic acidosis, right? So metabolic acidosis from an elevated anion gap, and that anion gap is elevated because of lactate, because of ketones and other organic acids. So you have a respiratory alkalosis, okay, with an anion gap metabolic acidosis. This is a classic board question. It does happen in real life too. It's important to know. Respiratory alkalosis with metabolic acidosis, an anion gap metabolic acidosis. So do note though that this metabolic acidosis develops later than the respiratory alkalosis in most adults, although children may present predominantly acidotic earlier in their course. All right. Pathophysiologic principle number 4. You start to get a lot of glucose dysregulation. So the salicylates, as we said, increase metabolic demand. That increase in metabolic demand is secondary to a lot of that uncoupling. That then increases glucose utilization. Increased glucose utilization can produce hypoglycemia because you start to run out of glucose. This is really important, right? Hypoglycemia is one of those possible symptoms of salicylate toxicity. The next sentence I'm going to say, though, is really, really interesting in an unfortunate way. Because the other thing that can happen is even when you have normal serum glucose, you do a point-of-care glucose check or you get a glucose back on your basic metabolic panel and it is normal, you still actually can have hypoglycemia in your CNS glucose depletion. And we're going to get more into this. But what can happen is the salicylates can penetrate the CNS, okay? And when they're in the CNS, they can cause separate dysregulatory malfunctions in the CNS that can lead to hypoglycemia in the CNS despite a normal serum glucose level. So patients may have, you ready for it, neuroglycopenic symptoms even when the fingerstick glucose appears normal. I'm going to say it again. Patients may have neuroglycopenic symptoms even when the fingerstick glucose appears normal. This is why in some patients, if you are symptomatic, even if your glucoses are normal, you might still start a dextrose solution to try to drive up that CNS glucose. Interesting. Gosh, toxidromes are wild. Okay, pathophysiologic principle number 5. Sorry, we are such pathophysiology nerds, but in our minds at least, understanding the pathophysiology really helps the rest of things settle in, right? We're going to be talking about management, signs and symptoms, severity, all that kind of stuff, and understanding the pathophysiology will help us understand why all those symptoms are rising and how to manage them. So principle number 5, CNS penetration and acidemia. Hopefully some of this is kind of falling into place because there's a lot of overlap. We've mentioned these things. So this is the most dangerous physiologic turning point in salicylate toxicity. To understand this, we have to understand ionized form and non-ionized form. So salicylates exist in an ionized form, which means it has a charge, right? Ionized means it has a charge. And a non-ionized form, it's neutral, there's no charge. The non-ionized form of salicylates can cross the blood-brain barrier much more easily, right? So you have a brain, we can't draw to save our lives, but this is going to be a little brain, squigglies. But this brain is surrounded by a blood-brain barrier, okay? And this blood-brain barrier only lets in certain things. One of the things that it does let in, though, is the non-ionized, the neutral salicylate molecule. And this neutral salicylate molecule then can get into the brain and wreak havoc in there, all right? Now, acidemia, right? We said these patients have a respiratory alkalosis early on, and then they have an anionic metabolic acidosis. Acidemia shifts salicylates towards the non-ionized state. So if this acidemia gets bad, ionized salicylates, right? They're ionized, they have a charge, so they don't readily cross the blood-brain barrier. They start to shift into the non-ionized form of salicylates, and the non-ionized forms of salicylates, as we said, can cross the blood-brain barrier and cause the terrible CNS effects you can see. So as serum pH falls, CNS salicylate penetration rapidly increases and the neurotoxicity worsens, which is really critical. This can lead to agitation, delirium, cerebral edema or swelling of the brain, seizures, coma, right? All these things can end up being fatal. Even small drops in the pH can dramatically worsen toxicity, which we need to remember this because it's going to play into some of our management approaches, which aren't as maybe typical for patients who are coming with different other complaints. This is why acidemia is dangerous. This is why hyperventilation, that respiratory alkalosis, is protective. And this is why, and we're going to talk way more about it, but intubating these patients can be catastrophic if ventilation is inadequate, right? Intubating these patients can lead to death because we need these patients to maintain their respiratory drive, to try to hyperventilate, increase their minute ventilation, and drive an alkalosis, because any worsening acidemia is going to increase salicylate CNS penetration and cause worsening CNS effects. All right, on to the 6th pathophysiologic principle, and this is the last one. So if you've made it down here, you're a pathophysiology nerd like the rest of us, let us know. If you've decided to dip out or skip ahead, this is the last one, so skip a little bit further, I suppose. Okay. Pathophysiologic principle number 6 is pulmonary edema. This isn't your run-of-the-mill pulmonary edema. Severe salicylate toxicity can actually cause non-cardiogenic pulmonary edema, right? So cardiogenic pulmonary edema is you're fluid overloaded, you have heart failure, and that causes fluid
to back up into the lungs and cause pulmonary edema. Non-cardiogenic pulmonary edema means you don't have heart failure, you're not fluid overloaded, there's something else causing fluid in the lungs. And the mechanism is poorly understood, but people think it's from increased capillary permeability in the lungs, maybe direct lung injury, maybe increased metabolic stress. So it's unclear what's totally driving this, but you start to get pulmonary edema that is not from the heart. And this may cause hypoxemia, infiltrates on chest x-ray, respiratory distress, and being unable to adequately ventilate can worsen acidemia and start the vicious cycle of toxicity, right? Increasing that CNS penetration because you have worsening acidemia, leading the salicylate to go from ionized to non-ionized, which then can more readily pass the blood-brain barrier and get into the brain. All right, good work. On to a brief discussion, emphasis on brief, on the classic acid-base pattern, because this is something commonly tested, and we do see it in patients in the clinical arena, which makes it even more important. Some things are tested, but you don't really see them. Some things you see them and aren't tested. This is one of those things that check both boxes, which is atypical and critical. All right, so adults classically develop, and you all, if you've been paying attention, hopefully could fill this in. Adults classically develop a respiratory alkalosis. Remember, this often happens first. It's because that salicylate affects the medullary centers in the brain, which increases our respiratory drive. This is followed by an anion gap metabolic acidosis. This is usually second or later. And this is because you get the uncoupling of oxidative phosphorylation. This increases lactic acid. This increases ketones like beta-hydroxybutyrate. And all these things contribute to an anion gap metabolic acidosis. All right. Children may present with a metabolic acidosis earlier, but just note that a near normal pH does not exclude severe toxicity, because a near normal pH might be a combination of your respiratory alkalosis plus your metabolic acidosis, your anion gap metabolic acidosis, and this may lead to about normal pH, but you still may have severe toxicity, so don't let that fool you. Again, this is commonly tested on, so put that in your brain hole. All right, clinical features of salicylate toxicity. A lot of these things hopefully will be explanatory in the sense that we understand the pathophysiology, and many of these symptoms are related to that. So early findings of salicylate toxicity: nausea, vomiting, tinnitus, which is ringing in the ears, tachypnea, right? Because you have a respiratory alkalosis, because that salicylate stimulated your medullary centers that increase your respiratory drive. Diaphoresis, because you get a little hypermetabolic. You have dysregulation of your thermoregulatory centers, and it causes you to be hot. Fevers, same thing, diaphoresis and fevers. And dizziness, because you start to get some early CNS penetration. So you can start to see how some of these symptoms line up with the pathophysiology we talked about. This then can progress to moderate toxicity, and this is where things start to get bad. Agitation, confusion, right? These are because of increasing CNS penetration, right? You might get more acidemic, which will allow more of that ionized to non-ionized salicylate to get into the brain. Start to get tachycardic, right? This tachycardia is primarily driven by the fact that you're no longer able to oxidatively phosphorylate, and you are not making as much energy, so your heart goes into overdrive. Hyperventilation, you still have that respiratory alkalosis, and then ketosis, right? Because again, you've uncoupled oxidative phosphorylation, your body's starving for energy, so it starts to perform ketosis by breaking down fatty acids. So, right, pathophys, it all comes back to pathophys. Okay. Severe toxicity is where things get deadly, and hopefully you've diagnosed and intervened before here, but you start to get altered mental status, seizures, coma, right? This is severe CNS toxicity. You get that non-cardiogenic pulmonary edema from pulmonary capillary leakage. Again, hyperthermia, your thermoregulatory centers are all deranged. You get a refractory acidosis from that uncoupled oxidative phosphorylation, increasing lactic acidosis and ketosis. And it can eventually lead to cardiovascular collapse, right? And this can certainly obviously lead to death. So this is a potentially fatal ingestion, very complex, and potentially fatal. Hard to diagnose too without someone telling you they took a bunch of salicylates. So good transition, important diagnostic pearls. Tachypnea here is protective, so note that. Patient might be tachypnic early. This is to maintain an alkalemia, because this alkalemia will change the ionized version. This alkalemia will change the ionized version of the salicylate to the ionized version, and the ionized version has a charge on it, so it does not cross the blood-brain barrier as easily. Pulse oximetry can be misleading in these patients, right? Oxygen saturation does not exclude severe toxicity, so don't let that make you feel falsely reassured. And then do note that salicylate levels can rise late. So some aspirin is enteric coated. You can get a Bezor. This is where you take so many pills, right? If there's your esophagus, goes into a curve, you got your tummy, and that tummy dumps out into your small intestine. If you take a bunch of pills, right, sometimes they actually stick together and they form this Bezor that's all clumped together and sticky, and this takes more time to break down and get metabolized. So Bezor formation can cause salicylate levels to rise late. Delayed gastric emptying, right? Some people have gastroparesis from things like diabetes or just delayed gastric emptying in general. All that can lead to salicylates rising late. So always obtain serial salicylate levels. Don't assume the first one or two is kind of the peak that you're going to come across. All right, initial evaluation of these patients. We're not going to spend too much time on here. Again, none of this is intended to be acted upon as medical advice. It's all just educational, but you can see some generic labs. A lot of these labs are kind of generic toxidrome labs. You want a basic metabolic panel, liver function tests, arterial blood gas or venous blood gas, serum salicylate, lactate, glucose, ketone, CBC, coags, Tylenol level, because they might have mixed polypharmacy, pregnancy tests if applicable. And again, a lot of this hopefully you're starting to think about, right? The BMP and CMP, the blood gas, because you initially have that respiratory alkalosis and then get metabolic acidosis later. Serum salicylate levels, but do remember that they might not peak quickly, especially if you have an enteric-coated aspirin ingestion or Bezor formation or polypharmacy. Lactic acid, because you get uncoupling of oxidative phosphorylation, that lactate goes up. Glucose, because you can get hypoglycemia, and you need to consider CNS hypoglycemia, that neuroglyco hypoglycemia. We actually forgot the cool name, but we are so interested in the cool name, we are going to scroll up and say it again so that we can all say it together. Oh boy, it was higher up than we thought. Bear with us. Or we're going to have to punt, and then you can tell us in the comments what we forgot. All right, fine, we'll punt. Let us know in the comments the cool name for hypoglycemia in the CNS. Something like neuroglycopenia or something. Okay, ketones, because you're no longer using oxidative phosphorylation to create energy, so you start to break down more fatty acids, which form then ketones. CBC, coags, classic toxidrome labs, and then a Tylenol level, because polypharmacy is quite common. EKG, chest x-ray, remember there's a non-cardiogenic pulmonary edema that can develop. And then remember, serum levels support diagnosis but do not determine severity alone. A patient with severe symptoms, acidemia, or CNS findings may be critically ill despite moderate serum levels. Some people say to trend them every 2 hours, although your poison center, we should have said this even earlier on, your poison center is your best friend. Use them, call them, talk to them. They are so helpful. All right. If you live in the States, you can, if you don't know the number, you can literally just Google it. Say poison center number near me, or poison center Illinois, or poison center Michigan, or poison center California, or wherever you live. So use them. All right, let's talk about a little therapeutic approaches. The first thing to mention is activated charcoal. This is a tough one, right? You can consider it if the presentation is within several hours, their airway's protected, the patient's cooperative, but just note, right, call poison control or talk about this with your local toxicologist. The decision to activate charcoal is complex, but it can work in salicylate toxicity, so it is an option on the table. The cornerstone of therapy, though, what is going to save lives is alkalinization, which hopefully you're thinking about why based on that pathophysiology. So why it works. Remember, alkalemia reduces CNS penetration because you go from ionized to non-ionized. We are going to constantly say that wrong. Revamp, you go from non-ionized to ionized, because ionized has a charge and has less CNS penetration. It also helps you increase urinary excretion of the salicylates. This is how you get rid of them. This is really important. So this is the key therapy for most symptomatic patients, right? Alkalinize them. Target a serum pH of 7.45 to 7.55, a urine pH of greater than 7.5, and use bicarbonate to do that. Do note that these patients have to be normo hypokalemic, their potassium has to be normal because potassium is critical in urinary alkalinization. Hypokalemia will prevent you from being able to adequately alkalize the urine. So ensure potassium is within normal ranges and replete it as you need to, because without it, you might not be able to alkalinize that urine effectively. So alkalinization is the key therapy here, right? Use bicarb, do it. Fluids, patients are often volume depleted, right? Hyperventilation causes insensible losses. We don't have to think about that, but if we're panting away, we're losing fluids in our breath every time we're panting. Fever, vomiting, all these things are going to cause hypovolemia. So resuscitate these patients with fluids, but do remember, some of them develop non-cardiogenic pulmonary edema. And although that's not a volume problem, dry lungs are happy lungs, or so they tell us. So you just want to be careful. You want to be thoughtful about that. Glucose management. We have mentioned this a couple times. We're going to keep hammering it home. CNS glucose depletion may occur despite normal serum glucoses. Give dextrose if they have neurosymptoms, altered mental status, neurosymptoms, or even a borderline serum glucose, right? So give them D5. When in doubt, probably just start them on a dextrose solution. Intubating these patients, oh goodness, this is a high risk maneuver. So intubation can kill these patients. This is one of the highest risk airways in emergency critical care medicine, because any apnea, any hypoventilation can rapidly worsen acidemia. And this rapidly worsening acidemia, even with brief hypoventilation, can precipitate cardiac arrest, right? This makes us incredibly nervous. So avoid intubation if at all possible. Try non-invasive if they can tolerate it. Give bicarbonate, fix their glucose, address their volume status, do everything you can to potentially reverse or improve them to avoid intubation. If you have no choice left, the patient is going to die without being intubated, this is a physiologically difficult airway. Be thoughtful, have a plan, and get ahead of this as best as you can, right? Bolus them bicarbonate as much as you can to drive that pH up before you induce them to intubate them. Prepare the ventilator in advance. Avoid apnea at all costs. If it's interesting to you, let us know. We can do a whole episode on kind of physiologically difficult airways. There's a lot there to think about, and this is probably not doing it any justice at all, because there's a lot of thought and steps you can take to try to make this incredibly dangerous high-risk airway maybe a touch less dangerous, although certainly does not take the majority of the risk away. The other thing to note is once you put them on a ventilator, you really need to try to match or exceed their pre-intubation minute ventilation, right? Minute ventilation is respiratory rate times tidal volume. This is the cc's of air they were breathing per minute. And that is what their body needed to stay alkalized. So you need to try to match this or supersede it, because if you don't, their respiratory alkalosis that is helping save their life is going to go away, and they're going to get more acidotic. And remember, acidemia kills these patients. So they may require higher respiratory rates, larger minute ventilations. If you did not paralyze the patient, you can trial pressure control rather than volume control, because pressure control will let them take big tidal volumes in a way that volume control doesn't always let them. Now, you got to be careful with pressure control because the tidal volume is an uncontrolled variable. So if they're breathing okay in pressure control and you step away and all of a sudden they start breathing less, again, they could die. So this is a very high risk intubation. This ventilator is going to need a lot of close attention. And the things here are apnea and hypoventilation kill these patients. So you have to decrease apnea time, ensure you are alkalizing them, and once they're on the vent, try to match their previous minute ventilation, which is a hard thing to do, but allow them to take high tidal volumes. This is not the patient you put on 6 cc's per kg a tidal volume and hope for the best, right? That will be an assassination attempt. Okay. Other management principles, hemodialysis. This is a definitive therapy for patients with severe salicylate toxicity. It removes the salicylates, corrects acid-base derangements, corrects electrolytes, removes fluid as you need to. The common triggers here, this is complex, so again, talk to your subspecialist, whether it's poison center or toxicology, but CNS symptoms like altered mental status, non-cardiogenic pulmonary edema, that's severe acidemia, renal failure, rising salicylate levels, clinical deterioration, refractory electrolyte derangement, severe hyperthermia, inability to effectively alkalize. All these are possible indications, but pull in your subspecialist. This can be a complex kind of decisional tree, and one that can change over time too, right? A decision to not do it can change an hour later, and it might be a decision to do it, but hemodialysis is definitive therapy for these patients, and it can save their lives. So don't drag your feet. If they need to be dialyzed, put in the dialysis catheter and get it done, right? Let's keep them alive. We can pull the dialysis catheter out later. All right, major pitfalls. We're close to the end. We got some pitfalls, some high-yield board pearls, some final kind of clinical bedside pearls, and then practice questions. So if you made it this far, finish it out, and you will maybe be the master of salicylate toxicity, or at least well on your way. All right, pitfall number 1, intubating without matching their minute ventilation. The intubation procedure is high risk, but putting them on the ventilator even after that remains high risk. So be very thoughtful, right? Hypoventilation or even lack of hyperventilation can kill these patients. So this is not a low tidal volume, minimized ventilator-induced lung injury patient. This is get them breathing as high as a minute ventilation as you safely can. Pitfall number 2, focusing only on salicylate levels. Remember, their symptoms are critical for severity of ingestion. Don't anchor just on the level itself. Missing mixed acid-base disorders. If someone comes in and they don't readily tell you they have, consumed excessive salicylates, this can be a tough diagnosis. So if you see acid-base disorders, even with a normal pH, right? Look at your CO2, look at your bicarb, think about salicylates, okay? This is critical. Not rechecking salicylate levels is pitfall number 4, right? Someone might have enteric-coated salicylate, someone might have a Bezor, they might have delayed gastric emptying. These levels might go up as time goes on. So trend the levels and use your subspecialist to aid you in those decisions. And then pitfall number 5 is forgetting potassium replacement. Remember, hypokalemia will make it very hard to alkalize the urine. So ensure your potassium is being repleted so that you can alkalize that urine and try to get them to start to excrete and urinate off some of that salicylates. All right, high-yield board pearls. We're going to leave this here. Again, if you're interested in printing this out, you can annotate it, take it with you, do whatever you want. It's on our Patreon page. We're not going to spend too much time. We'll just read these, but high-yield board pearls for tests. Tinnitus and tachypnea, think salicylates on tests. Respiratory alkalosis is usually the earliest abnormality. Acidemia worsens CNS toxicity. Hyperventilation is compensatory and protective. Dialysis is the definitive treatment. Trend the salicylate level serially and make sure potassium is replaced. Right? These are all things that might come up on test questions, and they're good to know to take care of these patients too. Final clinical takeaway before we get into practice questions, see what we actually maybe learned. The major physiologic battle in salicylate toxicity is maintaining alkalemia. This prevents CNS salicylate accumulation. The sickest patients often deteriorate after acidemia, respiratory fatigue, inadequate ventilation, or delayed dialysis. Recognize this early, give bicarbonate therapies. Do not intubate them unless you have to, and if you do, goodness forbid, minimize apnea time and ensure you can try to hyperventilate to them on the ventilator. And do not delay dialysis. Dialysis will save lives. Okay, when in doubt, dialyze it out. All right, let's get into 3 practice questions. This is the last part of the episode. For those that have not done practice questions with us before, what we will do is we will read the question, we'll read the answer options, and then we'll go right into the answer. So if you need more time, just make sure you pause the episode because we'll go right into the answer. We go basic, intermediate, advanced in terms of difficulty. Question number 1. A 24-year-old woman presents after an aspirin overdose. She is tachypnic with a respiratory rate of 32 breaths per minute. Initial blood gas demonstrates a pH of 7.49, PaCO2 of 24, bicarbonate of 19. Which acid-base disturbance is most consistent with salicylate toxicity? A pure metabolic acidosis. B, a pure respiratory alkalosis. C, mixed respiratory alkalosis with a metabolic acidosis. Or D, mixed respiratory acidosis and metabolic alkalosis. Pause if you need to. The correct answer is C, right? Salicylate toxicity, you tend to get mixed respiratory alkalosis from that increased respiratory drive, followed by a combination of an anion gap metabolic acidosis from that lactate creation and ketone creation. All right, so this is the classic acid-base pattern. The respiratory alkalosis usually happens first, followed by the anion gap metabolic acidosis. And if you're watching this in video form, we got a longer explanation for the question, but we won't belabor it here. All right, question number 2, intermediate. A 67-year-old man with chronic salicylate toxicity becomes progressively confused. His pH decreases from 7.46 to 7.33 over several hours. Why is this particularly dangerous? A. Acidemia decreases urinary potassium excretion. B. Acidemia increases CNS salicylate penetration. C. Acidemia prevents activated charcoal absorption. Or D. Acidemia decreases serum salicylate levels. Pause if you need to. The correct answer is B. Acidemia increases salicylate penetration. Remember, non-ionized or neutral salicylate has much better CNS penetration. So when we get more acidemic, ionized salicylate becomes non-ionized with acidemia, and this then penetrates the CNS more readily. All right, last question. We'll just pause the video here so you guys can see the explanation if you want to. Again, pause it. You could read it if you're watching this in video form. All right, last question, question 3, and then we will be done. Leave you all to enjoy the rest of your day. A 32-year-old woman with severe salicylate toxicity is intubated for worsening agitation. Shortly after intubation, she develops bradycardia and cardiac arrest. And this is really can happen, everyone. Which mechanism most likely contributed to her deterioration? A. Excessive urinary alkalinization. B. Rapid decrease in serum potassium. C. Loss of compensatory hyperventilation causing worsening acidemia. Or D. Increased salicylate protein binding after intubation. Pause if you need to. The correct answer is C. Loss of compensatory hyperventilation causing worsening acidemia. As we said, right, intubating these patients is so high risk because no matter how hard you try, it's really hard to not lead to any degree of hypoventilation or apnea, right? You can do awake intubations, you can do all this stuff, and certainly there's approaches that will decrease this risk, but it's really hard to maintain a patient's minute ventilation when they're already breathing like crazy while putting an endotracheal tube in, and this can cause worsening acidemia even briefly, which can lead to more CNS penetration and honestly sudden cardiac arrest. This is something that does happen, which is why we really try to avoid these patients, intubating these patients if we have a choice. And again, just like before, we'll leave the longer explanation here if anyone would like to pause and read it. All right, that is all we have for you today. Thanks for checking out the episode. Let us know what thoughts, comments, questions you have down below. We are so stoked about our YouTube community and Patreon community, so if you want to join those, we'd love to have you. Check them out. And either way, stay well, keep learning, and we hope to see you next time. If I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients.